let me tell you a little bit about David, my friend. He's been a dentist for many, many years. He graduated Emory University and had several, how many years? 20 some odd years in general dentist, and then kind of branched out into the field of tempomandibular disorders. And he studied with Mark Piper. He studied at the Dawson Institute. He's been through the whole Pankey Institute. He's still quite active nationally with groups of other types of specialists in tempomandibular disorders. So we're going to learn this morning some interrelations between dental and tempomandibular things, which I bet most of you, I've not found them to be at many meetings where we're going to get this much clarity. So David has 3 kids and 7 grandkids, so he's not as young as he looks. And he's got a lot of experience. He's got some things that he asked me not to tell him, but I will tell one. He is a world-class kayaker. He was attained a level of expert and has international and national records from competition. So he says that's a past life. So maybe since he is not an underachiever, we'll gain some information this morning. Welcome, David Jones.
Thank you. Austin's going to try to keep the volume up here so that you can hear me. Everybody hear me in the back? I hope it's not reverberating too badly. You hear me back there in the back? Okay. Okay. It's been a rough last 2 weeks for me. 2 weeks ago today, I disembarked from my first and last Disney cruise. And let me assure you, when you go on a Disney cruise, you come home with more than memories. The last night there, we went with my oldest daughter and her 4 kids and her husband and my wife. And so my wife and I are in a room with our 2 oldest grandchildren. So you have to pack up all your luggage, put it in the hallway, okay? So you get 1 change of clothes, right? So my grandson started throwing up violently in the middle of the night. He didn't even get out of the bed. So it's all over everything, all over his clothes. He had diarrhea terribly, so changed him, got him in the shower all night long. That was what we were dealing with. So the next morning, I got up, put on whatever clothes he had left, fortunate enough to cover him. We went off the boat. Immediately, it started going through his whole family, okay? So my wife and I both got sick last week. Now, neither one of us got all that bad problem, but she got a bad chest cold. And I got up sick last week and had fever and went to bed, and then it passed, and I thought, great, I've missed it. I've dodged a bullet. Well, sure enough, about Monday or Tuesday, I could tell I'm going to lose my voice. It's going. So I'm just nursing this thing. I called my physician and say, come on, you got to help me here. And she said, oh, it's probably virus. And if it's virus, guess what? Too bad, you're just going to lose your voice. Nothing you can do about it. I thought, you're a big help. I'm paying your money for this. So as it turned out, I kept thinking, what do I do? So I got a son-in-law who's in a rock band. They're on tour right now. So I texted Nate and I said, Nate, what do y'all do when you start losing your voice? I got the longest text back. It was like 4 different steps. Some of you old people remember your mama sticking your head over the pot with a Vicks vapor rub, and I've been doing that. I've been gargling 3 or 4 times a day. I've been using the throat lozenges. I've been doing the throat coat drink. So keep your fingers crossed that I keep my voice. Okay, so as you can tell, my title is the Tempromandibular Joint. It's not, most lectures you get are going to be talking about TMD, the Tempromandibular Disorder, and I'm certainly talking about TMD today, and there'll be a lot of discussion about ways to manage it, ways to treat it, and everything else. But my focus is on the joint because I think that's really overlooked a lot. Even in the TMD discussions, people don't really talk about the joint. And there's one goal for me is to have a better understanding, to have a better understanding of exactly what goes on at the joint level, so that when you see your patients and something's going on starting in your mind about, okay, what's going on here with this TMJ? What exactly is happening? So you can get a better understanding about it. So, of course, we got to go with the disclaimer. I don't get a single penny from anybody I mention or any products I mention or anything else. So I'd like to also give a special thanks to Mark Piper, Jim McKee, and Elizabeth Kagi, who's my associate, for allowing me to use some of the materials today. Mark has been gracious enough to let me use some of his slides as it shows the joint being damaged, which are just excellent. I think you're going to appreciate that. So let's talk about the goals I have today. I tried to get these so that it would be kind of teaching points that I hope you can kind of focus on and not too overwhelming for you. So first of all, what have we been taught about TMD and occlusion over the years would be the first topic. And then what's the reality of it, of that disease? And then what new knowledge helps us to understand TMD problems? How does the TMJ get damaged? How do we treat TMD patients? So the patient that comes in your office, what's the best way that we can treat them and render them service? And then we're going to look at cases. Okay. Now, this lecture is based on my empirical knowledge that I've gained over the last 14 years of specializing in this field. And, to kind of tell you my walk or my history about this, because not everybody thinks about going into dentistry and I'm going to be a TMJ specialist or a TMD specialist. So, as Leon alluded to, I graduated from Emory and practiced in Buckhead here in Atlanta for 30 years in a private restorative practice, and loved it. Loved my patients. Had a wonderful staff that stayed with me my entire practice almost. My assistant I acquired the day I bought my practice, and she was there 30 years later when I left. She was wonderful. And so I really loved the restorative aspect of it, but they were going to tear my building down. And I got word about this, and I thought, good gracious, I'm in my mid-50s, I don't owe anybody any money. Do I really want to start over? But I didn't really want to quit dentistry because I love this profession. So as it turned out, I got an offer to, sell my practice. I'm going to have to do a lot of this today, drinking water, because I took a decongestant. So I got an offer and I took it. When you get an offer for cash, you take it. So I took the offer and worked for the guy for a couple of years. And then in the meantime, my oldest daughter started developing TMJ problems. And it was one of those situations where it first started off, she had a water skiing accident, and dislocated subluxar mandible out and didn't tell me about it. And then she finally told me she had done it, and so I'd been to Pankey and Dawson and everything, so I made her a splint, and she was fine. And then she had an automobile accident, rear end collision, about age 20, and 22, something like that. It started cascading down from there. So as it turned out, she would come in and I'd adjust the splint, and she was hitting on just nothing but the right back molar. I keep adjusting the splint. And it get it balanced, then she's just hitting on the right back molar. Well, she goes off to college. She went to school at Sanford in Birmingham, and then she stayed down at UAB to get her master's. And lo and behold, she gets a job as a missionary in Vienna, Austria, teaching at a missionary school. So she's gone. So I see her twice a year. And over that period of time, she just went from sweetest, easiest going to miserable pain, miserable migraine headaches. And her bite totally collapsed. She ended up went from a mild class, well, it'll be more of a class 1 malocclusion, which was orthodontically corrected. But she went from that to almost a 5 millimeter open bite in the anterior teeth, couldn't get any teeth together. And I was at a loss. Here I was her dentist and her dad. So it got real personal for me right at that point. So I ended up going took her to a couple of people, and what you do the usual route, you take her to an oral surgeon. Well, they don't want to deal with it, have very little knowledge about it really. And then I took her to a TMJ specialist who I really respected, but he missed the diagnosis. Didn't do any imaging, and kind of said, well, I think she's going to be all right. And I said, she's not going to be all right. So in that process, in that journey, I ended up deciding, you know what, I need to get educated about this. And so I was sure enough, I had sold my practice. I was heading down to drop off a case to Gordon Brady at Oral Surgery Associates. They just opened an office up in Buckhead. And I went down there to drop off a case on my youngest daughter, who he was going to do a maxillary osteotomy for orthodontics. And so I went to drop off that case. And I guess Gordon had a bad day because I walked in and he said, "David, do you know anything about TMJ problems?" And I said, "Well, actually, I've been studying this. So you want a job?" I mean, it was that. He doesn't remember it that way, but I do. And literally, boom, overnight, I was in a TMJ specialist. And so this has been a journey for me. It's been, so this is what I'm trying to present here is what I've gleaned over 14 years of doing this. Now, not everyone in my field will agree with what I'm going to say today. But this is what I've found to be true. We're all prone to mistakes in dentistry. We're human. We're going to make mistakes. And sometimes we make mistakes in judgment concerning our treatment for patients. Now, sometimes some judgment decisions are a little bit worse than others. And you just hope none of these happen to be in your dental field. So, however, unknowingly every day, we end up making decisions about our patients, judgment decisions about treatment. And that's about a number. Everybody's squinting. It's probably about a number 8 wood screw is what that is. But unknowingly, every day we make judgments about restorative, ortho, and everything else, and we have never taken into consideration the foundation of what all that is being built on, where those teeth are going. And that's what I'm trying to get across today, is that how important the TMJ is to the foundation of what you're going to do in your dental work. So I use this quote from the book of Luke. He is like a man that built a house who dug down deep and laid a foundation on rock. And when the flood occurred, the torrent burst against the house and could not be shake it because it had been well built. Everything we do in life is built on a foundation, whether it's our spiritual life, family, business. It's all established on a firm foundation. Proper foundation in dentistry is needed as well to ensure success. From preparation to impression to cementation, if you've done the right work and prepared correctly, it's going to be successful. So I hope at the end of this lecture we'll give you enough foundation to work with on how to diagnose these cases and be able to do a better job in treating your patients with TMD problems. So let's start off about what we've been taught about occlusion. The TMD, this is the definition that is pretty standard, collective term referring to number of problems involving the musculature, tempromandibular joints, and associated structures. Well, that's a pretty broad term for, what that is. It could mean anything. You got pain in the head and neck. I mentioned my journey. I have to ask, to a crowd like this, why did you come to this lecture? There's a lot of lectures to pick. Why you come to this lecture? And usually it's because I told my staff they had to, but I had to have somebody here. But the other reason I think is a couple of reasons. One is that you're curious about this subject. You are interested in it. There'll be some of you. Vast majority, though, you're here because of one of 3 reasons. You've got a patient you've had problems with. You don't know what to do with them, and you'd like to help them. Or it's you, or it's a family member like me that is suffering from this problem, and you really want to get them help. I see a lot of heads nodding. I know that's the case. So WebMD has a little site called Medscape. These are great. I don't know if y'all ever get these, but they'll send it to you, and you'll get it on the internet. It's great because it's tests about all kinds of things medically. Diabetes too, joint replacements. They'll talk about cardiovascular disease or heart problems. And, it gives you a little 5 quiz to take, and then it'll tell you about the answers and stuff. And I think it's very informative, very good for you as a practitioner to know this because your patients have these problems and you need to understand what they're dealing with. Well, sure enough, this came out about 3 weeks ago. So I sent it to all my buddies who do TMD and said, take the test. I took the test. I only answered 3 questions because 2 of them I thought didn't have correct answers to them. So, yeah. I'm just trying to let you know that we don't all agree on what TMD is. That's why there's not a specialty in this field. You got endodontics, periodontics, oral surgery. You don't have a specialty of TMD because we can't come to a meeting of minds about this. So, and you know what, folks? This isn't politics. We don't have to hate each other's guts just because you disagree with each other. In fact, debate's good. We need to debate these issues because if it brings us closer to the truth, that's what we want to see. So let's get started with this. Okay, 30-year-old facial pain patient, all right? See these people walking in your practice every day. Pretty smile. Oh, by the way, let me give you a note here. I'm going to use my cursor. Y'all see that okay? Instead of using the laser pointer, because when they videotape this, they're videotaping the images with my voice over it. And this way I can be able to point out things on the video for people. So I'm going to use this instead of a laser pointer. Also, I don't have to walk away from the microphone. So we see these patients every day. You know, class 1 molar, class 2 cuspid, pretty smile. Got a little bit of irritation of the gum tissue right up in here. But outside of that, no worn dentition, beautiful teeth, clean teeth. She has, looks great. Now, the problem is this person's been suffering from pain for 10 years. No remission. So when they come in and we're trying to work on them, what we tell them, let's put in a filling. We do a little restoration. So how do you check it? Tap, tap. How's that feel? And great. So you let them go. Of course, you realize you have them blocked with anesthetic, so they're probably not really getting the correct tapping, but we treat an MIP, maximum intercuspation. I always wondered why we put a P on the end of that word. We taught that at Emory, but it's really MI. But MIP, that's where we treat. But we're taught from Dawson and Pankey to look at CR. Of course, you want to get in a fight with somebody, let's try to get a definition of CR. But you see bites like this all the time. But if the patient comes in with myofascial pain, what do you do about it? They come in, they've had all this pain problems. Well, Pankey trained, I was taught, put them in a splint. Put them in a splint, get them comfortable, and you get them comfortable, and at that point you have to make a decision. What do you do about that bite? Do you do anything? If you want to try to recouple those front teeth, you're going to have to either reline, reshape, or restore. That's about all your options are. But most of us would say, pretty bite like that, pretty teeth like that, keep them in the splint. They're happy, let them go. Don't do anything. Everybody's happy. And that's what we tend to do. A lot of times we're not recognizing the problems in patients. Patient comes in, she's got a little bit of a neck issue with a head tilt, but we're not, unless the patient volunteers the information to us, we don't find it out. I don't know about you, but when I was in practice, I'd come in and the first thing is, how you doing, man? how are your kids, how are your grandkids? You get a conversation going, you're just excited to see them, and you ask them, you having any trouble? All the time they say, nope, everything's great. They want you to be Sherlock Holmes. They want you to figure out something's right. They don't want to tell you. The only way you hear it is the hygienist says, they can't open very wide, or they're popping when they open. That's probably the only indication we know that something's going on. So what do we say to them? Does it hurt? No, it just makes noises. Whew. I dodged that bullet because now I don't have to do anything about it. So I said, great. Just kind of watch your diet and be careful with it and whatever. And we're just glad that they leave because you don't really know what to do about it. And in fact, do you do anything about it is more important. So if they don't have a problem, they don't volunteer it, you're not knowing what's going on. That's where the hygienist, I think, is absolutely the gatekeeper here for a lot of these problems, because she can pick this out. She's the one that's got to keep their mouth open and work on them. And so I think that the hygienists need to be letting the dentist know that these problems exist, and then you can start investigating a little bit more. So if we look at the history and look at the literature, it all started with Clyde Wilkes, who came out with his stages of TMJ damage. You know, up until about the mid-'80s, temporomandibular joint was covered in orthopedic and surgical handbooks. The surgery was covered, and then all of a sudden it just disappeared. It became the redheaded stepchild that it still is. Nobody wanted to do with it. Insurance don't want to cover it. All of a sudden, it just disappeared off the books. So it basically fell in the lap of oral surgeons to be the guardian of this. And Clyde is the first one to come up and give us this kind of code of how these things work, how the scale works. And it's still the most recognized classification that we have of TMD damage. That's one most people recognize. However, most people don't really know what it means. Because if you really look at what he's got there, disc displacement with reduction in intermittent locking, without reduction, limited opening, without reduction, without limited opening, and degenerative joint disease, I think the only thing you could really say, I know exactly what's going on in this joint, is the very last one. They got a degenerative joint. But when you start talking about variations of a pop or a click, people can't, that's, like, I can't figure out what that is. What's that pop mean? I don't know. And so you got to realize that this is Clyde did this up empirically, feeling it with his finger. They didn't even have Doppler back then. Feeling it with his finger and listening with a stethoscope. That's the only way you could do the diagnosis. So that's why he came up to the stage, and I think it's pretty ingenious he was able to do that. But it's limited in what it tells us. And then in 2014, Schiffman and his group came out with this report, and it's a continuation report that started in '92 that talks about the classification system is based on a biopsychosocial model of pain that includes what they call an Axis 1 assessment using reliable data to measure it, and then an Axis 2 assessment of psychological status and pain-related disability. I think the key to look at in this here is that this protocol was for TMJ research, okay? I'd be willing to bet most of the people up here, most people in this room have never seen this report because it's in academia. This is what they deal with in the university level. Academy of Oral-Facial Pain kind of uses this criteria. And so this is, it's different. I'm going to speak a little bit about Axis 2 later in the lecture. I won't talk on it much now, but let's really just talk about Axis 1, because that's what we kind of focus on. And if you look at this, Axis 1, they break it down into two models. One is the myofascial pain problem people have, and then the joint problem. So myofascial pain, this is how they list it. Well, myalgia basically is just pain on functioning or parafunctioning. So just chewing. Local myalgia is pain on palpation, so you push it. And then myofascial pain is you push it and it spreads. So they have all these variations of what pain in the head and neck mean. The interesting thing of this is they don't really show any issues about the neck. And we're not going to really cover the neck in here, but I'll tell you right now, 80% of my patients that come in with a TMD problem have neck issues too. So it all kind of goes hand in hand. And we'll talk about why, but that's part of it as well. So what do you do with these patients? Well, we treat them. They're mostly muscle-based, with the exception of arthralgia down there. These are muscle-based pains. And so what we end up doing with these people is you do exactly the right thing. Ice, heat, stretch. Don't use it. Put them in a splint. Those all work. Those all work for this. So, but when you get into the joint, if you'll notice something, this is Schiffman's classification, and it's basically Clyde Wilkes' classification with the addition of subluxation. So they've taken 2014 and 1989. There's been no change in diagnosing the joint. So you've got basically the same. Subluxation is where you've opened the joint past the eminence and locked it open. And it's a rare occurrence. I've seen it once in 14 years. So they haven't changed the classification for this. So I think in 25 years, you should have made some progress in figuring out what's wrong at the joint level. But it's interesting, even with this classification, at the end of each classification, they would tell you the only way to confirm this diagnosis is with an MRI. So it kind of makes you wonder why in the world then they just use the MRI in the first place to kind of confirm the diagnosis to start off with. So when we look at what we've learned about this, what the dentists are taught about damage, you basically have two options. This is what we learned in school, that you had two options. The deuce, and this is what all that classification boils down to, two options. The disc is off, so you have the disc off here. You open and you pop back underneath it here, and you close and you come off of it. And then you have number two, in which the disc is off. You open and you push the disc forward. You do not recapture it or reduce it. You close and it's back to the other position. And so basically you have it opens and it clicks or reduces, or you open and it doesn't click, doesn't reduce. And that, to me, for 25 years, back and forth, it seems like we haven't made much progress in understanding exactly what's going on at the joint level. But I'd be willing to bet that's the vast majority of people's concept of what goes on at TMJ level in this room. So what were we taught about TMD and occlusion? Well, it's a pain problem that results from fatigue of clenching and grinding. That's what Laskin reported. And then we were taught also that a sustained lateral pterygoid contraction from clenching and grinding can result in a disc displacement. In other words, the posterior interference in the bite triggers the lateral pterygoid to contract, which will pull the disc off. In other words, bad bites make bad joints. We were also taught that TMD patients have psychological issues that cause clenching and grinding. That's what Laskin also reported here, that since this explanation implicates emotional rather than mechanical factors as a prime etiologic agents, it has been termed a psychophysiological theory, which is basically the psychosocial. So it's people clench because they have issues. It also, we were taught that it affects a small percentage of the population and is self-limiting. What were we taught? We were taught that panoramic x-rays are diagnostic of TMJ damage. I have a buddy who's orthodontist in South Africa. He's moved now to Perth, Australia, but he sends stuff out from time to time. He's the one that provided me with the number 8 screw in there. He loves to send those things out. But he sent this to a whole bunch of his friends saying, look, how do we go about treating this? I'd really like to know, do I take out the second molar here, let the thirds come in? He'd send it out. He sent it to me by mistake, I guess. And I emailed him back, said, Chris, your left TMJ is distracted out of the condyle, but it looks pretty normal. But look at this guy over here, condylar hyperplasia. You can do orthodontics to the cows come home, and all you're going to end up with an asymmetrical jaw and no bite. So whatever you do is not going to matter whether you've got wires on the teeth. And he thanked me, and then he hasn't sent me any more cases to evaluate. But the point is, until you get it to this level of damage, you can't see damage on a TMJ. And I'm going to show you a comparison of a patient that I've been treating of the panoramic x-ray. These were all taken within 4 months of each other. Panoramic x-ray, CT scan, and the MRI. And it's just unbelievable the level of damage it got to, and it looks normal on the panoramic. Also, panoramics don't show soft tissue. And the reason for this is that the condyle, and I'll tell you about this, is 20 millimeters long. So when you did an x-ray in a two-dimensional plane, it's going through 20 millimeters of material. So if you've got a normal healthy side of the joint and a destroyed side of the joint, the healthy is going to overshadow the destroyed one. So it's going to give an image of appearance of normal. So what techniques have we been taught to diagnose TMD? Well, a thorough history. We take records. We look at symptoms. We load test it. We do bite analysis. And those are all good. I mean, we need to do all that stuff. And also it's geared toward pain relief. So we're looking at what's going on. So we're looking at what the pain is, and if we can diagnose that, treat them with a splint, get the pain to go away, then usually everybody's happy. But pain's not diagnostic of pathology. So you can have no pain and have a serious problem, just think of cancer. I've known too many people who got to stage 4 before they were ever diagnosed. So it's important to gather all this information, but I think the problem is it's incomplete. So what's the reality concerning TMD and inclusion? Now, once again, I have to let you know this. This is my observations about this problem. So first, TMD is a pain problem of the head and neck. Okay, we were told it's a small percentage, but I think you're going to see that it's different. Treatment focuses on reducing the symptoms, so we all know that too. That's what we all do, and that's what we want to do. I mean, we need to do that for our patients. But at the same time, you need to be looking at a deeper level. Growth and development problems in young children are quite often overlooked in these problems, in cases. Changes in bite and lack of anterior guidance in adults may indicate damaged TMJs. Tooth interferences do not typically displace the disc. Now, it may be heresy for somebody for me to say that, but truth is, I believe it now. I'm a good friend with Pete Dawson, but I do think now that we're seeing other reasons why TMJs are damaged and not this. I'm not saying this is 100% of the cases. There may be cases that a contracted lateral pterygoid may pull off an already damaged TMJ, but it's not going to initiate that damage. Panoramics are not diagnostic of TMJ joint damage. TMJ patients are frustrated. By the time they've gotten to me, they've been to 4 doctors. Their general dentist or their physician, an ENT, maybe another TMJ specialist, and or physical therapist, and then I see them, and they open their case and dump out the splints on the table. So they tend to see a lot of people. So if you can, as a practitioner, be the clearinghouse for it first and recognize it, it's going to be beneficial for them for time and money. High risk of TMD patients can comprise 30% of your practice. And the disease is only self-limiting after years of pain and discomfort. And I will show you as we go through the classification scale I'm going to give you, that's the new one I want you to kind of remember, and is in your handouts, by the way, that the only time a TMJ gets self-limiting is if the bone of the condyle stays healthy, blood supply stays healthy, it will go to sclerosis, just like a knee or anything else, and be hard and eburnated bone and everything else. But it takes a 5 to 7 year period of pain to get there. So when people just cavalier say, oh yeah, it's self-limiting, they're not the ones living with the self-limiting pain. What new knowledge helps us to better understand the TMD problems? Well, it's imaging. And this is the thing that I think is the thing we've overlooked for so long, but CT scans, and a lot of you have access to those, even if you don't have one in your office. You have a friend, a periodontist, oral surgeon, who can take a CT scan for you and provide you with a disc so that you've got that for your file. So this information is readily available for patients now. TMD, MRIs have been around for 30 years. Kurt Schellis did this study years ago showing that it was vastly superior in contrast to the soft tissues as compared to conventional imaging, because you're going to be able to see the soft tissue here as opposed to just bone. I think the reason we've missed this for so many years, if you look down here, by the way, also note that Clyde Wilkes was part of this study. If you look down here, this was in a radiographic journal. I think one of the problems that we had is that it just hadn't come to our attention. It's been published in other areas, and it wasn't in the forefront. We had other ways to diagnose things, and we were just kind of slow catching on to it. But there's no reason now that we shouldn't be utilizing it. So let's take another look at our 30-year-old facial pain patient. So as you can tell, the upper bite is actually her MIP, and if you can hold questions to the end, I got a lot of material to cover. And if you just hold it, write it down if you need to, and I'll try to answer everything then. But if you look at this patient, okay, from that, you've got this class 2 bite in fully seated condylar position. Now, I use that term instead of CR, and the reason is centric relation is only exists if the condyle is properly positioned in the fossa against the disc correctly, and it's a healthy disc. That's the only time you can say it's CR. And you don't know that. You're not going to know that in your analysis until you really have an image. So I use fully seated condylar position because if you manipulate the jaw to seat in that position, like Pete taught us how to do, it's going to seat somewhere. It might not be on the disc. It might be on the posterior band of the disc. It might be on soft tissue. But that's the fully seated position. That's where the jaw really wants to work and operate, but it might not be able to do it because of the disc. So, but that's where she is. Now, that's a serious class 2 bite. What percentage of the population is a class 2 bite, especially that severe? If you look at statistical analysis, 3 to 5% of the population is genetically class 3. So, if you were to believe in bell curves, then you'd have to say 3 to 5% of the population is some sort of genetic class 2. But if you ask an orthodontist, he's going to clearly tell you it's probably 25% of the population. So what makes up that difference? Is the difference because we just missed that and we've got a skewed statistical data, or is it because of the fact that we have damaged TMJs that are creating class 2 bites in these patients that are going undiagnosed, especially in these young children? It can be kind of disastrous because they lose the opportunity to grow that joint, and they've missed it by the time it's diagnosed. So if you also look at the lower picture down here, that's an incisal edge position. That's one of the bites we take when we do MRIs. It's very telling when you see a patient go end to end like that, and they don't touch their front teeth, and they're touching on their posterior molars. You almost always can say, if both sides are like that, they're missing the disc bilaterally, okay, completely. Because your incisal guidance and your eminence and your joint grew together around the same time. So in that development, the people with a pretty gradual eminence have a pretty gradual incisal guidance, and people with a very steep, locked-in vertical have a pretty vertical incisal guidance. So that eminence is pretty steep. And that's, you see, it's not blanket, it's not hard and fast, but for the vast majority, that's the way it is. And so when she comes out forward like this and she's going to hit her back teeth, it means that there's no disc protecting, separating that condyle as it comes down the eminence. And so because that's separation is what separates the back teeth as you come forward. So what it's going to do is bang. So this is what you'll see every time. So if we look at the joint and centric relation, and I'll call it centric relation, this is the fully seated position. What you're looking at here, this is the posterior band of the disc. It's thick. You have this thin intermediary layer, and this is the anterior band. Now the posterior band has some retrodiscal attachment that's hooked onto the back. This is a venous shunt, and it's attached to the superior belly of the lateral pterygoid here and the inferior belly of the lateral pterygoid at the bottom. The inferior belly connects to the condyl's neck, and the superior belly connects both to the condylar neck and to the disc. This is the main opening apparatus of the TMJ. And when it's in this position, the disc is usually in a 1 o'clock position, meaning the posterior band up here at the back is between 12:30 and 1 o'clock where that attachment is. That's healthy. It has a normal retrodiscal volume, meaning when it's closed down there's very little retrodiscal tissue showing, but you'll see when it opens, it engorges with blood. It's a fully grown condyle. So the condyle here, like I told you, was 20 millimeters in length. The width of it is about 8, and that should be about 2/3 the width of the fossa, of the glenoid fossa. It has stable condylar bone. You normally see kind of a roundish shape to it, but I tell you what, a radiologist buddy of mine who reads all he's come to believe now that there's a lot of anomalies in condylar shape, and that are not driven by necessarily lack of disc being in position. So I think that's true, but at the same time, you don't want to see a flattened off condylar head. You don't want to see bone beaking, which I'll show you some. So you want to make sure that or thickening of this cortical plate. You don't want that cortical plate to be real thick. That usually shows it's going sclerotic. So, so the bone's stable. The lateral pterygoid's relaxed in the closed position. And it's seated with the condyle into the disc, and it defines the projection of the mandible when you open. So if you look at an MRI, and what I've tried to do on a number of these slides, first of all, that's the reason I told Leon, tell everybody moved up. I took all the MRIs I had and blew them up, just so I'd get them as big as I could so you could see them on the screen, and I hope you'll be able to see them from in the back. But if you look at this, I've outlined, if anybody ever tried to draw on a computer, this is a nightmare for me, and I'm an artist, but my hand just shook and shook. I had these little wiggly lines. I could not get those things straight for the life of me. But I've put the eminence in red, and I've put the condyle head in yellow and the disc in blue. So all of them are going to look like that. They all have the same kind of outline. So what you're looking at is, this would be it without the lines. You can see it clearly. This is a proton density image. It shows a clear image of the disc, condyle in place, pretty normal position. So that's what it looks like normally. So if you look at it translated, okay, first thing you do is the disc is interposed between the condyle and the eminence as it's open. You can see this retrodiscal volume increases. It's a surge of blood that fills it. Body doesn't like a vacuum, so when you open, blood flows into that. One thing we've also found out lately is that retrodiscal tissue is not nearly as innervated as we thought. And I'll tell you about that after a while, because it used to be, we always used to think if you load tested and somebody was sensitive, you were pinching retrodiscal tissue, but I'm believing now that that's not true. I think what you're doing is pushing the disc a herniated disc into the lateral pterygoid muscle. It's muscle braced, okay, so meaning that the lateral pterygoid's in contraction, but you also have the extension of the masseter temporalis mediopterygoid being taut on the other side. So it's kind of in a fixed position. And there you go, there's the muscle braced. And it projects the mandibular posture as you open. So that's what dictates how the jaw opens. So this is what it looked like. And when you get there to the end, my squiggly lines and all, and you get there to the end of this, you can see that the disc kind of misshapens a bit. The posterior band gets kind of bulbous. And that's exactly what it's supposed to look like. So it's a very pliable type of disc material. It's not just hard and fast. So it moves as the joint moves. You know, God had an idea when he designed this thing, and he made it to work correctly. We just mess it up. So let's talk about the classifications of TMD. So here's what my main goal for you today is. I want to show you this new classification. I put it in your handout, and it's a little 2-page synopsis in there. So you don't have to catch everything I'm going to show you here, but I think what you're going to find is, as we kind of go through this, I'm hoping it's logical, that you can kind of logically think about the progression of what's happening to the joint as you do it. And you know, Wilkes provided such a great classification to start off with, but with advances in imaging, we just can go to a different level now. And I think it's time we did. Okay, so let's start off. It's the Piper classification of TMJ damage. Mark Piper is an oral surgeon in St. Petersburg, Florida. And when I was in my process of having this epiphany about TMJ with my daughter, I'd finished Pankey, I'd taken all of Dawson, had finished Pankey, and I asked Pete, I said, Pete, you know, I've taken his, I don't know if you've ever taken his number 3 class. I took his number 3 class 3 times, I think. It was a great class on treating the difficult mouth. But I said to Pete, I said, you know, what do I do next? He said, well, you ought to take Mark's class on TMJ. It was perfect timing because I'd taken the first class. And when I took the second class, we had to present a case, so I presented my daughter as the case. And that got me hooked because then I've realized she had a serious issue. So Mark came up with this classification years ago, and the Piper scale is, and we're going to go through each one of these individually, so don't even think too much about what I'm showing you right here. But it's like a wheel, Okay, 8 stages, and it's going around a clock face. And what you have to remember about TMJ damage is as it progresses down this clock face, you're not going to go backwards. So the idea that my TMJ stopped popping and everything's fine is not true. It's just gotten to a different stage. So you cannot recapture a disc unless you do it surgically, period. So as we go through this, I'm going to show you different sections of this, of what damage we're looking at. So there are several different types. If you look at the soft tissue damage, the outside is the bony problems that you have. So we remember the hyperplasia in the young person that I showed you before, overgrowth of the condylar head. We're looking at proportionate growth, normal growth of the condyle. Osteochondrosis, which is a lack of growth of the condyle. And you see that in young people when the disc has been lost early. Young childhood injury, disc has come off. The disc is the growth symphysis for the joint, just like it is in every other part of the body. And if you take that off, the condyle doesn't grow. And so therein lies some of the reason for some of these class 2 cases in these young children. They didn't have a jaw that grew, and they're termed genetically class 2, but they're not. So you end up with these really small joints with no disc. You have over here osteoarthrosis, which is, this is going to self-limit. This is where bone's going to get hard against bone, and that will be stable at some point, but it takes a while. Osteochondrosis dissecans, which is pressure point problems in a joint, where you have pressure on a particular part of the joint and it will end up having a vascular problem. Then avascular necrosis, which we'll talk about some, which is usually occurs because of a lack of blood supply to the condyle. And the transitional down here is the worst of all cases, osteochondrotic type of condyle with a avascular necrosis that goes in. Unfortunately, I see way too many of those cases. And all of that is dictated by the disc. So when you're talking about the disc coming off, now once again, remember it's a 20 millimeter long disc, so that long disc doesn't have to just come off forward. It can come off to the lateral pole out toward the ear, or it can shift off to the medial pole. And if it comes off laterally, that's good. I mean, if you're going to lose it, because it's not going to cause any problems. That joint will go to arthrosis. If it goes off medially, there's a chance it can block the blood supply going to the neck of the condyle. And if that happens, you're going to get avascular necrosis, and it can happen quickly. So that's why it's very important to kind of figure out where it's going, the direction of it. So if you look at the Piper classification, we'll break it down here. This was in Pete's book. Class 1's normal. Class 2 is an intermittent click. Class 3 is where just the lateral pole, or the outside of the disc, has come off. And this, now Piper 3B is the lateral pole's off and you're not recapturing it. Then 4A is medial pole's off. 4B, the medial pole is locked out, you're not recapturing it. 5A is perforation, and perforation is not of the disc, it's of the retrodiscal tissue between the disc and the retrodiscal tissue. That's where the perforation occurs. With acute degenerative joint disease, this is active damage going on, and then 5B is the chronic stage. So let's look at the morphology of the disc itself. As I described before, 20 millimeters in this direction, 8 millimeters in this direction. It's got a little bend to the neck. This is the entrance of where the blood supply comes into the neck of the condyle down here at the bottom. Here's the disc that sits on top of it. It's fibrocartilage, not hyaline. It's attached at the medial and collateral and lateral poles with a ligament. It has a capsule that surrounds it. It is all part of the condyle, not with a skull base. Okay, and it allows the disc to move freely in that joint with the attachments. So let's go through these stages one at a time, and I'm going to show you how the joint breaks down. So if you start with this, and the way you're going to look at this is going to be a sagittal view from the side. Here's the disc sitting on top of the joint. Here's the lateral pterygoid ligament. This is the coronal view, meaning front to back look. And this is the axial view, meaning looking at it from the top. So all of these are going to be in the same plane. So first of all, you got an intact collateral ligament on the lateral pole and the medial pole. So those are intact. It's in centric relation, because this one truly is in centric relation. And the disc aligns normally into that position, no laxity in the ligament as it sits there. And it translates normal in position, and the condyle remains beneath the disc as it is in dynamic occlusion or open. So that's normal. Normal joint, no problems. It's painless, noiseless. Anytime you have somebody has pain in a normal joint like that, it might be a spasm in the lateral pterygoid muscle that's creating if they feel it deep like that. So stage 2, intermittent click. This is the person who went over to the Subway and got the sandwich and it was too big for them. Took a bite, something felt funny. Or they wake up in the morning, it's clicking because they've been clenching their teeth. Sometimes clenching can decrease the synovial fluid around the disc and make it sticky. So you'll have some mayhem clinking with that. It's usually minor trauma. These are the patients you tell, rest it, take NSAIDs, ice it, that sort of thing. And sure enough, they're better. It will heal. So what you have here is some laxity at the lateral colligament, lateral attachment. But the medial is intact. And then you've got, in centric relation, it's in position, but the ligament is kind of loose at that point. But the disc is still on there. And then in the translated position, it's completely underneath it. So everything looks normal. So if you go to Piper 3A, this is where the disc first comes off, and you're not getting it back. So this is where the joint starts clicking. This is the patient comes in to your office and says, Doc, my joint started popping. And they say, well, how long has it been? Oh, a couple of weeks. I said, is it painful? No. Does it bother you eating? No. And that's the one you go, whew. So, and this is actually, this is joint damage, but not severe, not serious. And so what you find here is that the ligament is torn at the lateral, and so the disc is displaced slightly forward off of the condylar head, as you can see on the right side. But the medial pole is attached. And as long as the medial pole is attached, then the joint's stable, because that's what's braced against the skull base. That's what's rotating in the final arc of opening, and it's going to keep your bite normal. That's when you go back to closure, it's going to be still intact and you're going to have normal bite. The bite's not going to change. So Piper 3s are okay. They're livable joints damage, okay? So in the fully seated position, the disc is off on the lateral pole. In a translated position, it pops back underneath it. That's what you're doing. You're recapturing the disc. And so in dynamic occlusion, it comes back. So the 3B is where the lateral pole doesn't come back. So here the ligament's off. The medial pole, once again, still attached. Fully seated, it's off. As you translate, you're not recapturing the disc. It's staying locked out. But you still have the medial pole there, so that's good. So you've got brace. And this is the important point to remember. Stages 1, 2, and 3 are typically not any kind of surgical cases. These people work really well with splints, managing the joint, managing the pain from clenching if they're a clencher. But you can treat these patients. You can do orthodontics on them. You can do restorative work on them. So this is not the problem. The problem comes when you get to stage 4, because this is an issue with stability. This is the reciprocal click. A lot of times you hear it where they pop on and they pop off. And you'll hear that in these patients, not always. And the motion can be restricted at first sometimes, but a lot of times will normalize itself. So you're off on the lateral ligament and you're off on the medial ligament. Both of them are torn and the disc is slipped forward slightly. So you can see that area in the middle here is sort of where the retrodiscal tissue is shifted forward onto the condyle head, where you're now putting some pressure on that. And then you're off in fully seated position, but But when you open and translate, a lot of times the complete disc pops back on top of the condylar head. So there's a lot of chances in these patients that you can recapture that medial, not only medial pole, but lateral pole as well in fully opening. And that's good, because if the disc isn't damaged too bad, that can be surgically repaired and put back as long as there's not damage to the TMJ. So if you go to 4B, this is where the pole stays locked out. This is where you start getting trouble. A lot of times the motion's restricted at first because the disc kind of is interfering with its ability to open. But as time goes on, you kind of keep pushing the disc out further in front of it so it goes away from the joint head. And here's where you start seeing a progressive occlusal shifting starting. So you're going to see changes in the bite because you realize now the ligaments are torn medial and lateral. And what you have now is that this disc is completely off in this area and in the closed and open position. So you're starting, as you translate forward, you're starting to translate on soft tissue. And that's not going to hold up. Eventually that's going to wear through. And a lot of times the body takes what it's given and tries to work with it. So you'll find the body try to take that tissue and make it firmer, but it eventually will get worn through and punched through. So as you're in that closed position, the disc, as you can see, is totally forward, fully seated. It translated position, it doesn't recapture, and it's locked behind it in dynamic occlusion. You can also start having problems if the disc has gone medially here. You're going to start seeing problems with potential avascular necrosis starting with the joint. If it's going laterally, it's going to be more sclerotic in nature. Now the 5A is the real bad boy. This guy is the worst. This is where you start hearing the real bad joint crepitus, the sandy sounds in the joint. A lot of times the range of motion can be normal in these patients, but you see a lot of progressive occlusal shifting, especially if the joint is, the blood supply is damaged and you have avascular necrosis. You'll see collapsing bites pretty quick. So it's off on both poles. You can see the exposed bone now because now you have perforation of the retrodiscal tissue. That bone, as you can tell, is going to be wearing directly into the bone of the eminence. And when you start seeing that, this is assuming it's sclerotic and not avascular necrosis. When you see that, what you'll start seeing is a flattening of the eminence too. So you'll see this condylar shape that was covered by the eminence, both of them tend to flatten out. What you find is that the condyle will grow a beak. It'll flatten, it'll look like a bird. We'll show you some pictures of that. And the eminence will flatten too to accommodate it. And that's a natural process of trying to give more surface area to the condylar head and to the system to let it stay stable. So that's what you see when you see it move forward. It's going to be bone-to-bone kind of connection. And then when you get to 5B, you get a change. If it goes to 5B and is chronic, this is good if somebody's got this problem because it will eventually get stable. This is where it's bone-to-bone. As we can tell, nothing but bone's exposed. The disc is totally deformed and out of position. And as you move forward, it's bone tissue to bone tissue. And it gets hard, flat. It's like ivory up there. But it's noisy. A lot of these patients are really noisy chewers, and they hate it, but because it's right in their ear. But, a lot of times these bites are stable. So the key takeaway, I know that's a lot of stuff, I'm sorry, but the key takeaway here is the first four joints, but the first three classifications are okay. If you get a damaged joint, that's a lateral pole pop or click, whether it reduces or not, a lot of times that's a stable occlusion. So if your patients aren't having occlusal problems, bite changes, that sort of thing, there's a good chance whatever clicking they've got might not be damaging. Not a hard and fast rule, but that may be the case. And this is the one that's more problematic, is when you get into this, you're going to have changing bites. So this is why I very seldom will pick up a handpiece and adjust a bite on a patient if they've got a tooth that's interfering. Because I need to see what that interference is. Because if you take that, you've just adapted them to the joint that's damaged. And that might be helpful for a moment, but then 2 months later, you're adapting it again. And then again, and then again, until you kind of worry about obliterating the occlusion. But you can help them get adapted to this, but you need to see what's going on at the joint level before you start doing that, because what you end up doing is finally getting to a point, you don't have an end point to it. The person has to get to the end point. So let's take a look at our chronic pain patient, okay? What you'll see, these are old MRIs, so apologize for that. But what you'll see I outlined here is this is the left TMJ, and this is in her closed position, this is in the open position, okay? And what you can see is she's off the disc, closed. You can see the beak that's developed on that condyle. And when she opens forward, she pushes the disc forward. She doesn't recapture it. She's just short of it. And on the right side, same thing, except for she has more flattening of the condylar head here, so there's more arthrosis in there. So I'd be willing to bet that the disc is going probably lateral here for her. But she is a Piper 4B 5A out in here, and she's a Piper 5A on this right side. Now, the problem is she's been suffering 10 years with that. She could have had therapy or gotten that fixed years ago, and it would have been a lot better off. She'd have been a lot better off if she had. So let's talk a little bit about occlusion, because everybody's so quick. Let's talk about occlusion. But we've got to realize that occlusion now in the presence of a joint that's your foundation is going to give you it's going to be a different occlusion than you looked at before. So now that joints play a role in how the bite is, so the old perspective we had was how do teeth fit together? That gave us our bite. We look at them, we're taught in dental school that, and we gave people bites for that. But the new one is now how the lower teeth fit the upper teeth together and where that is in space. So you've got to have the jaws fitting together and the teeth fitting together to be able to kind of be able to say, what is my occlusion? So if we look back at what we were taught, we were taught Angles classification. That's what we were taught at Emory, and I'm sure most dental schools. And there are different types and different divisions of these, but for vast majority of us, they're either class 1 molar, cuspid, right, left. I mean, we didn't really get into the nuances of the Angles classification, but we had class 1, 2, and 3. And that's the one that most people are familiar with, and I think is held for a long period of time. But it doesn't relate to the joint at all. So Pete Dawson came out with his classification a number of years ago, and I'm sure they still use it at the Dawson Center. The problem I have using Pete's is that I'm just not skilled enough to do it as well as he does. But it's based on MIP. So it's based on MIP and load testing. And in my realm of what I do, I've fallen out of favor with load testing. And I've fallen out of favor with load testing mainly because I would get too many false negatives and positives. I never really knew where the joint was. And I wasn't sure whether it was, where I was on the disc or not on the disc or whatever. And I never really felt secure about what I was seeing with load testing. So I always end up kind of in a no man's land of a Dawson 3, which means you couldn't verify where the disc was. So I quit using that scale. I know some people probably still use it, and that's fine, whatever works for you. But I think the one that I like best now is a modified Angles, because Angles is the classification we all grew up with using. And I think it's the one that we are more familiar with. So if you look at Angles classification, it's image-based. So we base it on the MRI. The treatment position is coming from the MRI, and it's a fully seated position. And that's where the jaw wants to be. So when you look at that, and you basically, the way this works is pretty simple. You've got Angles 1, 2, and 3 going from left to right, top to bottom, okay? So those are all type 1s on the top, type 2s on Angles 2 on the middle, and type 3 on the bottom. So you can have a genetic or type 2 normal type 2 bite, type 3 bite, but the joint could be bad or good. So what you're looking at now is the joint normal? is it adapted or is it non-adapted? And what we see is that Piper 1, okay, is the normal joint, whether it's type 1, 2, or 3, Angles type. And then the adapted joint, okay, would be Piper 3s, 2s and 3s. So that's the joint with the lateral pull off. But the medial pull is stable, so it's no problem because you can work with these patients. The non-adapted joint's the transient joint. That's the one that's the 4 A and B and the 5A. And so that's the one you have to be worried about. So really when I'm looking at a patient and I'm checking their bite, I'm going to check and see whether their angles, molar, cuspid, right and left, and then I'm going to determine by my empirical evidence of the popping of the joint. This is prior imaging, and kind of get an idea of what I think's going on. But the only way I can really confirm that with these TMJ patients is have an image to confirm where that bite is. So that's the way I've kind of looked at the bites nowadays. I can kind of get an idea that it's a non-adapted joint or adapted joint just by checking them. So let's take a little bit look at some of the techniques that we've got now to help us. And I'm going to walk you through a couple of things like CT scans and MRIs, show you how these are read and see if it gives you some understanding of it. When you get a CT scan, we have it in our office. So CT scan in our, you get 4 basic films. You get the coronal view here looking front to back. So you've got both condyles here. You look at the sagittal view, and most of the images I'm going to show you from the cases are all going to be sagittal. And the reason being that they're easier to see. That's the way we look at a panoramic. That's what you're used to. So I'm going to show mostly those, even though we use coronal views a lot. And we use the axial view here really for orientation, but also to look at the length and size of the condyle from above. And then this is the one the patients love. They love this 3-dimensional thing. You spin it around and show them that there's no brain in there, you know. And so we use this to show it, and they like it, you know, but it's not diagnostic for us. You can take the MRI and actually plot points on the graph and do a correct panoramic X-ray, one that's exact. You can't take measurements off an old panoramic because it's just not exact. So here you can take measurements of the length of the ramus of the condyle, see if there's growth deficiencies. You can look at molar, what they call molar delta, see what the true class 2 relationship is, class 1, class 2, class 3 relationship is. But this view will give you a look, and you know, looking at the panoramic on this very normal joint over here, a little bit of bumpiness over here that I want to look closer to on this one. So if we look at this guy's left TMJ, it looks pretty normal looking at the coronal sagittal view, but you get into here and you can see he's got some real issues. This right here is just burnout on the film. As you scroll through it, you see it, but this area up here is what you're concerned with. And of course, once again, the kind of the 3D image that shows the flattening TMJ. One of the things that also you get is you get things that you don't expect. This is a calcification of the left internal carotid artery on this patient. He had no idea he had, his cardiologist had no idea he had. And so the only way we found that was because it came through on the report from beam readers. And we use beam readers for our CTs. If you're doing CT scanning, you know, if you're localizing it to one thing to do an implant, then maybe you can get away with that. But if you're doing the skull from the eyes to the C4, you need to have an overread, because I think you're liable for these things in this kind of litigious society we live in. I think you're liable for litigation if you left something undiagnosed. And these people do a great job. They charge $75 to just do an overread on your image, and you know, I just add that to the fee. The patient's getting this information, and you know, he took that to his cardiologist, so that was good. So we'll talk about MRIs. It's really starting to question whether I'm going to make this. It's getting, I don't know if you can tell, but I can tell it's getting less volume for me. This is Shell's report, came out in '89. So it's been a long time ago. This is what is amazing to me. High prevalence of occlusal disturbances in patients with TMD pain dysfunction led to the erroneous belief that TMD disorders are manifestations of underlying malocclusion. So the MRI is proven to be revolution in showing major disorders of skeletal occlusion, including acquired and or unstable crossbites, anterior open bites, retrognathia have been shown to be secondary manifestations of TMJ pathology in the mandibular condyle. So, this, like I'm saying, we've had this available for years. We just haven't used it. So let me just, I'm not a rocket scientist. This stuff's not hard. It's just like anything else you do in dentistry. You got to do enough of it to understand it, read enough of it to understand it. You know what? You get a good radiologist and they'll help you. Anybody wants to do a study club and read these things, I'll be happy to come and help you do it. But they're really easy. These are the main things we're looking at. T1 shows fat. What you want is healthy fat because fat shows health of the bone. So if the fat signal, which it should be white inside the condyle, if it's dark, then you realize there's a disruption to the blood flow, and there's a chance there's necrosis going on. The fat will die first when the blood is cut off. T2 shows water. And so you're looking for effusion, swelling in the joint head, swelling in the capsule. Proton density is a combination of the two images, and that's going to show you the disc, usually better. So those are the three we use. So we get the first one, it's T1 Scout. And what we're looking at on the axial view is we're looking at the shape of the condyles here. Two things are noted is the shape looks okay, and this one looks okay. But being T1, I'm worried about this guy because it's already black on this image. So I'm questioning what's going on with that right TMJ. We look at the coronal views mainly to kind of get us an indication of where the disc is going. So you can see in this particular area, here's the disc over here. That's the outline of it. So that disc, as it's seated, should be on top of the condyle here and evenly placed from this lateral pole all the way over to this medial pole here. So you can tell it's shifted a little bit more medial. It's not totally that way, but that's the way it is. We look at the T1s, and this is in sagittal. I hope you can see these images okay. But we're looking at the health of the bone. This is a normal, healthy T1 image. This is an abnormal T1 image. You can see that the condylar neck is totally bent. It's got a beak, and it's black. So I'm questioning avascular necrosis in that. Proton density image is going to show us the disc, and there's the disc right there in front. They look like a bow tie, as I showed you on that first image of it, normal TMJ. So it looks like a bow tie from sagittal. And then if you look at the T2, this is showing you water. So this is same patient, left and right, and he's got serious problems. But you got swelling posterior and anterior capsule or superior capsule. Then you got the swelling in the condylar neck and almost a cystic development of swelling in the condylar head. So that's a serious, when you get that swelling in there, that's pressure. And when that pressure is in there, that can create a problem. I use iConnect. iConnect is a program that is on the, you've got a login and password, and you can go to, the imaging center I use loads these on there so I can go anywhere and pull up a patient and look at their MRIs. Takes out the disc problem. So many of the problems, I have an Apple, they load it up at the hospital on a PC, doesn't read. So I can, this way I can get it anywhere I want. Also do a protocol, this is my protocol for doing imaging. I use 4 different bites I'm going to show you to acquire these images. And I do 12 different settings, which provides about 180, 240 images as we do them. So let me just mention this because everybody has a question about insurance with MRIs. I got to gas up here. Okay, one of the problems, when I first started doing these years ago, I never got questioned from the insurance companies about MRIs. It weren't a problem, but that's not the case now. So there's really 4 criteria that most insurance companies, everyone's different. Most of them are going to want their patients to have been through to get an MRI. And the first one on the list, which I always think is just ironic, is failed TMJ surgery or arthroscopic or open joint. And I'm thinking to myself, why didn't you do the MRI before you did the surgery? And don't ask me, but this is the world we live in. And secondly is a locked joint. Somebody that has a truly locked joint can't function, or locked open, which is unusual because you usually reduce that. But locked closed can a lot of times be almost difficult for them to function. 4 months of failed conservative therapy with medication. That means splint therapy with NSAIDs and or physical therapy too. So they make you jump through the hoop. And what I've found in some insurance companies, and this is a tragedy, is that a patient can have been through splint therapy for one dentist, they'll go to me, and they want me to do another splint for them to do that. And that, you've already had failed splint therapy. And if it's a decently made splint, there's no reason they need to do that, but that's what they do. And then medical necessity. Hyperplastic condyle, like that boy in that picture, growing. It's pretty obvious that there's an issue here from the radiograph. So it's not going to get better with 4 months of building up a splint that's 10 millimeters thick on one side. That isn't going to work. So let's talk about impressions I need for MRI. I send these patients off. I do these impressions in the office, put them in a little Ziploc bag, and they have to go into the image. Anybody ever had an MRI, you understand that nowadays they're semi-open. It used to be there was like, in a tube, and it's about that far from your face, so you're claustrophobic. Now that's about an arm length away from you. And they usually have a little mirror in the front so you can see the technician. So they're laying in there, and the technician says, okay, put in bite number 1. So they'll put in the bite, and they'll take this set of images, and they'll walk them through the rest of them. So what I do is I take blue mousse, and I inject it. I find fully seated condylar position, and I inject it and sedum to that first point of contact and hold it. I trim it. I put an arrow pointing up and a number 1 on it, and tell them the arrow, it's all on the right side, and the arrow has to point up. And it's kind of hard to mess it up. I haven't had anybody yet mess it up. Then we do an incisal edge position, like I showed you, to see where the condyle is in translation in anterior guidance. And that's number 2. And then I do a fully open one. These are Shine styrofoam blocks. You can get these Shine bag of 100, just nothing. And they've got a lateral hole going across the middle here. I take a pair of cotton pliers and bore a hole from the top to bottom, and then I inject blue mousse between those two so it locks it in. Blue mousse on top and bottom, seated in, gives them an indication of where to go with it. So what causes disc problems, okay? Anybody see this article in the ADA journal not long ago? It's the self-reporting tempromandibular disorders in kids. They had 8,300 kids in a 2-year study, half boys, half girls, and it was half white, half black. And the questions are what they called quality of health related, oral health related quality of life questions. That's a long little acronym they've got for that. And they ask them these questions. Does their face hurt? Does it hurt to chew tough foods? Does your jaw pop on wide opening? And does it hurt to open wide? And this is the conclusions they had here from that. A considerable percentage, 4 to 12-year-old children reported TMD symptoms, with girls and African American children being more likely than their counterparts. And that it significantly affected their oral health. And the implication is that practitioners need to be aware of this, that you can have these problems in elementary and grade school kids. So they say taking a dental history, conducting an exam before should be included in your assessments for signs and symptoms of TMD. Treatment recommendations should be provided to affected children. So the author's finding was, although future research should be explored, the way of children's health, that developmental changes might affect the prevalence of TMD, but overall there is a consensus that TMDJ is what TMJD they call it, is a serious issue among kids. Now, most pedodontists would say they don't see that. They don't see problems in the population. But a lot of times it's because those kids don't report the pain. They got a class 2 bite, they're going to send them to the orthodontist to get it corrected, but they're not having pain issues, so they don't see it as a problem. But most kids aren't going to manifest pain until they reach puberty in the joint. There's a whole bunch of reasons for why we think that's the case, but especially estrogen levels developing in girls makes you more susceptible to pain in the temporomandibular joint. So that's the reason. So really, though, if you think about it, so why are these kids having trouble with this? Well, trauma. You know, there was a report at the dental school, one of the dental schools that does TMD, there was a report that 69% of patients at dental schools, at TMD clinics, anonymously reported abuse. 69% anonymously reported some type of abuse. Now, that could be verbal, but I guarantee it's some physical. And if it's physical, they're not getting kicked in the shin. Okay, so, however, in that same clinic, only 25% reported TMD trauma, and that's what I find to be the case in my practice. Most people don't check anything on the trauma, so I'm end up having to, through my talk to them, get them to kind of come out, oh yeah, by the way, I fell off my bike at 8, or my little brother, you know, tackled me playing football, all these things. So I find that to be the safe, you know, the truth is, I tell people, you know, God didn't build this broke, we broke it. So if you look at trauma as being the most likely factor for this, there's several ways it can be damaged. Compression. You can get a blow to the chin, fall on the face. Stretch trauma. That usually comes from third molar extractions. You're partly asleep. I used to tell my colleagues at Oral Surgery Associate, I said, look, I'm not faulting you, and you need a bite block to get back there. I don't blame you one bit. And it's okay. But if a patient has a pop click, you need to tell them that. I've got to use this to get in here. It could make it worse. I just need to let you know. You know, it's a lot easier to ask permission than ask for forgiveness. So it's easier if you let them know ahead of time about this. I'm not saying you have to limit your treatment. You just have to be careful to inform them about what could happen. And this is the one that goes undiagnosed all the time. First thing I ask the patient when they have no history of trauma and they've got a serious TMJ problem, I said, do you ever have any surgeries? Oh, about 4. Or every time they intubate him, that guy's not caring about his TMJ. He wants to make them get a tube in there so they can live. So that joint gets yanked and things get done to it. And then you got whiplash injury. Whiplash injury, motor vehicle accidents, sports accidents are some of the worst. And if we look at just quickly on this, and I'll be finished in about 2 minutes, well, 4, but I'm on time. So motor vehicle accidents cause the biggest problem with TMJ issues, okay? So, and they're underreported. So what happens when you have a motor vehicle accident? You hit an object, boom, and the pressure from that airbag or whatever comes out and hits you, going back. You get the head coming forward, so you're getting the whiplash injury in the neck, cervical issue, and you're going to get a compression injury in the TMJ. So the jaw's going to be slammed forward up into the socket, and then the head's going to whip back against the seat, and what you're going to have happen is not only a stretch injury to the neck and the stretch injury to the TMJ, but you're going to have a rebound effect on it and you get a compression and stretch in the TMJ, and then it compresses again. So that's head on, and usually that's the one that most people can prevent because they're going to see it coming, and all they got to do is clench their teeth, because then your jaw's not going to move. Now, you're not going to stop the head problem, but you'll stop the jaw from being damaged. This is the one that gets you. It's the rear impact. You don't see it coming. Guy slams into you at 20 miles an hour, puts the force into the body, into the neck. Head goes back, stretch, compression. Head goes forward, compression. And you know, what you find happen in this is that it doesn't happen right away. They go to the emergency room, they get treated for whiplash, and usually about 4 weeks later, they stop popping or clicking. And that's when you notice it. That's almost every time. Or within a week or so after the damage, they can't get their back teeth together because of posterior swelling in the capsule. So, and there are other reasons why too. You know, we live in a world of raising jackasses. And I'm telling you, this, hey Bubba, watch this, is taken on a new level with cell phones and GoPros. So get ready. I'm turning off the sound because there's a few bad words being said. But you can see this sort of stuff doesn't get reported. This took a brain trust to figure this would work. And I'd be willing to bet alcohol's involved in this one. Ever had any damage to your head and neck? No. I've never had that. Get it all the time. And it can happen at an early age. That's all it takes. You know, with a motor vehicle accident, it only takes 8 miles an hour impact from the rear to cause a TMJ problem. This guy must have died in this. Well, this is a good one, too. Nothing like a big brother to help you out. This is the worst one here. This guy broke his neck, I think. This is like, hey, Bubba, watch, this is, who thinks, good gracious. She had a helmet on. Come on. I love this. The guy without the helmet is the one that takes the fall. Okay, even the corky gets in on it. Okay, so, poor guy. Okay, so let's take a 10-minute break, and then when you come back, we're going to talk about how you treat this, TMD and TMJ problem. So 10 minutes, be back here. You know, I'm an hour and 26 exactly. That's perfect. I'm going to try. I think so. Yeah. Because I'm going to give you some advice about that. Because there is definitely, I think there's still, I'm going to replace me. Well, if she can do it.
I just feel like you're family to me. And yeah, right. I feel like your name is just part of my day. We're not having you got her Piper actually together. Yeah. She came in with injuries so bad that she was set up to it was terrible. And we just before she had surgery scheduled. And we said, let us try to get some of this. Surgery. I work on it's funny that it's all the but anyway, I just want to hear you. Yeah, okay. I love it. It's been a process. I've worked
In ways, such a way that you're saying it's like a pivotal sport. Yeah, no. No, I've already created this. When it comes down. Okay. Leon, how are we looking? That 30. Yeah, probably 2 more minutes. Yeah, I should be finished right around. I can speed the cases up if I need to. I was expecting to finish my first day. You said.
So you got
Yeah. Yeah. I'm going to be way. Yeah. Yeah. We'll do it. Let me go. Thank you, Craig. What? Trauma? Okay, that's about right. Let's see what we should do how we go about treating this problem. I mean, I've given you history and sort of the idea of what causes TMD and TMJ issues, but how do we go about diagnosing TMD and occlusal problems? So, and this is some of this is in your handout. I've got sort of the protocol I give a patient when they come in, and the truth is almost every patient that comes in gets almost the same thing because I want to find out whether they have a muscle-based or a joint-based problem, or if it's something esoteric, nerve damage. I want to figure that out first. And muscles truly are going to drive the engine 75% of the time. So most pain is going to be muscle-based. And so what I got to do is get a thorough history. And that involves sitting down and talking with the patient. Now, I have the luxury of doing just this. So I spend an hour with those patients that come in to see me face-to-face. Now, it's not an assistant or a PA or somebody else doing that. It's me sitting down and talking with the patient. And I sit there and ask them 64 different questions because patients won't fill everything out. Like I said, in the trauma, they're just not going to list it. And it takes really kind of peeling that onion back to figure out when they did have trauma or whether they had surgery or something like that. And then I do an examination on the patient. I'm going to show you, I'm going to walk through sort of the examination stage of what I do and show you what we do. But the history comes first, so very thorough history. And then before I do the exam, I have them stand up against the wall, and I want to look at their posture. I think that's a thing that's largely missing in diagnosing these problems, postural issues. We live in a computer-obsessed age. And I call it the praying mantis position. You know, and to get glasses like this where you're reading through the bottom, and it's even worse. And I'm telling you what, that's just awful on the neck, on the head, jaw positioning. And so that's one of the first things I think I do. I want to see what their posture is. And I tell you what, there's some lousy postures out there. But you'll see people, they're canted, their heads tipped to the one side. They've got forward head posturing, and some ladies, dowager hump developing in the back, which is just, I have a code almost I have to say to my assistants about that because you don't want to say dowager hump because that immediately says that's old. But they get this humping in the back. But a lot of it's from the postural positioning. So I do that next. And then I do the examination. Then a lot of times with these patients, I'm going to put them on an aqualizer, and I'll tell you about that in a little bit and show you what that is. And HCI is home care instruction. And that's basically, and that's in your handout, that's basically icing and heating the muscle, stretching it. And physical therapists look at me like I've got it backwards, and I do, because I have them ice the muscle first and then stretch it, instead of heating it, stretching it, icing it. And they say, that's wrong. Well, yes, but if you've got a lockdown joint, people can't open 25 millimeters, and you're asking them to stretch it, they're not going to stretch it if they feel it. They just won't stretch it far enough. So ice is your anesthetic, numbs the muscle, allows them to stretch it a little further, then heat gets the blood flowing back into it. And then I have them back to reevaluate what went on. I give them a couple of weeks. A lot of times I'll put them on medication. Cyclobenzaprine is the one I use most. Trade name's Flexeril for muscle relaxation. Sometimes I'll put them on, if they've come in recent trauma, they've been in a car wreck, had a fall, and they can't get their posterior teeth together. A lot of times I'll put them on Medrol dose pack for a week, mainly because it's that inflammation in the socket. Get that down, and then I'll put them on NSAIDs. I'll put them on a NSAID after that. Usually if they've been in recent trauma, I can figure that out and do that. And then I start thinking differentially about what the diagnosis would be. Because, it's not always just muscle. It's not always just, a joint problem. You've got to start thinking about other things. You've got a patient in your practice, 50-year-old female, comes in, never had a issue in their life, and 2 weeks ago, they've got this raging problem in their temporalis muscle, And of course, I see these come in where they've been passed around by a few people, and they've come in because they've been told they had TMJ. But what it is they've got temporal arteritis. And so you can get inflammation of the temporal artery, and it's a severe, it's a deadly, potentially blinding problem for a patient. They go blind if they don't get treated. So things like that have to be picked up. So if you have these things come in, you've got to kind of eliminate the really bad boys, any kind of neoplasm, those sort of things. Very rare. I have seen one case probably in 14 years that there was some sort of neoplastic problem in the joint outside of hyperplasia, but a true questionable neoplasm in the joint. So it's very rare for the TMJ. You just don't see neoplasms in the joint there much, in my experience. And so you also have to be aware when you're interviewing these patients of, I told you about the axis 2 problems, the psychological problems. Evidence out now shows that I think the percentage is pretty high of patients with some sort of psychiatric problem. And I mean that generally like anxiety, depression, not somebody that's schizophrenic, even though that would be there too. But the main things that you're looking for, OCD, eating disorders, those people have a higher level of TMD problems than others. And so, getting that out, knowing they have an eating disorder, whatever. Also looking at sleep. Or do they have obstructive sleep apnea? Have they been tested? Is that quantified, or they just think that they loud snore? Those things ought to have to be looked at as well. And then after I get them back, if we decide to do anything, we'll do diagnostic workup. We'll do a CT on them. And then a lot of times I'm making some decisions. Do I do splint therapy? That's the conservative way. You want to do that. Do I do a complete workup with MRI? And how about diagnostic nerve blocks? Those are really helpful, and I'll show you what I do with those. But your patient comes back and can't get rid of pain in certain areas. You can block nerves in the head and neck superficially. Now, this is going to freak a lot of dentists out. This is like being a real physician. You're giving shots in the skin. But I'm telling you, they're so much easier to give than trying to try to find the mandibular nerve hidden back there in a buccal pad you can't even identify. So, I mean, these are not difficult shots, but everybody seems to freak out about them. And so then I'm looking for other, and then I'm going to, and I'll show you how that does, of eliminating pain patterning so I can isolate where the pain's the major source. And then I'm looking at other options. Let me go back here just a second. Of Atlas Orthogonal, that's what AO is, Atlas Orthogonal Chiropractic Medicine. Now, I was raised in a dental family. My dad was a dentist. He died when I was very young, and my mother remarried, of all things, another dentist. I mean, she didn't even like dentists. My wife said that about me too. And we were high school sweethearts, and she thought, I don't even like dentists. What are you doing? So, but looking at chiropractic medicine, I was just taught that it's just a bunch of bunk. That's just Ginzu. As I used to tell my kids, everything that wasn't traditional medicine, I called it Ginzu medicine. So last year, my daughter gave me a set of Ginzu knives. She found them somewhere. I don't know where it was, so it's kind of not traditional medicine. But I'm telling you, there's validity to Atlas problems, and we've seen it. And I've had remarkable cases. I had one case, I was telling one of the dentists in here, one case in which the patient had come in 30 years of almost constant migraines. Nobody could help her. Been on all kinds of medication. And when I checked her Atlas, it was hot. I mean, I could hardly touch it. And I knew that she needed a splint because she was a clencher, grinder to boot. And I said, it'd be unconscionable for me to go ahead and do that and not get you into the Atlas Orthogonal's hands first. Well, she went to him first, and one adjustment, and she hadn't had a headache since. I kept thinking, well, great, I just talked myself out of a splint. But she came back wanting the splint because she was a grinder. So a lot of times I'll do that in conjunction to help keep her from putting it into a stress condition. And then possibility of surgical workup, and we're going to talk about that. So this is what I do. I'm checking the muscles. I'm checking the temporalis. I'm checking the masseters. This is 6 pounds of pressure with your finger. Now, it's in the muscle body, not catching a tendon between your finger and a bone. You can make anything hurt like that, but this is pretty solid pressure against it to feel it. And if the patient says, well, I feel the pressure, that's good. But with that pressure, if they feel the pressure, then you're pushing hard enough. But if that pressure, if it's a bad muscle, hot muscle, will elicit pain. So I'm looking at the SCM, the mastoid, trapezius, occipital area. But the area they're looking at on the right side there is the atlas. That's right under the occipital area, and I'm palpating deeply into that area, putting pressure. And if you have a tenderness, it means the atlas is shifted one side or the other. And the muscles, the reason they're tender, the muscles are trying to pull it back into place. It's like a tug of war going on. We have what's called a joint vibration analysis system. I have no idea what this thing is. This is what my show associate uses, and it registers the opening closing cycle, and you can get it on a graph. But let me tell you something. I was 30 years in paper, folders. Everything was paper in my office. I was paper when I was at Oral Surgery Associates. So we're talking 40 years plus of paper. This year, when I moved to TMJ, started TMJ Treatment Atlanta with Liz Kagi, and her office is nothing but computers. I can't keep a sticky note in the place. I mean, it's unbelievable. And so when she starts throwing this other scientific stuff out, I'm the good old boy that goes back to the Doppler. So I'm just going to use a Doppler because I understand it, the patient can hear it, and it sounds, it gives them an indication of what. So this is magnifying the sound in the TMJ. It's better than a stethoscope, even though a stethoscope will help you. But I palpate that joint with my fingers first to kind of dictate to me, or get in my mind, which one's the worst. Because with that, you'll obviously hear a really bad pop translate across the head. So you got to identify which one's the worst first, and then listen to the joint. But we're listening to click, whether it's late or early. We're listening to crepitus. This is where you really pick up the crepitus in the joint. And crepitus can be of several types. It doesn't have to be just bone to bone. It can actually be a roughened disc or roughened retrodiscal tissue that you're rubbing on. So there are varying degrees of crepitus you listen to. I measure it, the open. This is a great little scale by Great Lakes. They're cheap, they're a little paper, but they measure the range of motion, and they're ideal. You put them right on the lower centrals and just have the patient open. So they'll measure your range of motion without having to get a ruler out and guess, or, there was a thing called TMJ triangle, and I kept being afraid I was going to drop that down their throat or something. But this thing works really well, and I take 2 measurements. I have them open to what's comfortable, no stress, no strain, and then I have them open wide. And if you get a patient that comes in that's 25 millimeters comfortable range of motion, and you have them open wide and they can open to 45, you got a muscle problem going on usually, especially if they say, that's really painful, but you don't hear a pop or click. And when they open straight. They don't deviate or have a declination around something that's in the way. When they do, if they open straight like that and can open right, then you're probably going to help that patient a lot with just a splint and helping them with it. This was the Aqualizer I mentioned I use in diagnosis. You can get these at aqualizer.com. You can go online. They have a place for dentists. You can go and you can order them in bags of 25. And I really prefer, what you find is after doing it as long as I've done, what's the one that fits most people? Because you just don't want a whole bunch of them sitting around the office. So I use the Ultra, and I use the medium volume. 90% of the people, that's going to work. And this is what we call a pivotal splint, okay? So it's aqualizer.com. Get it in packages of 25. You get the Ultra medium volume. You can get high volume, get low volume. What you find, the longer you keep these around through osmotic waves, it loses water. There are little bags of water that are connected by this channel. So what you've got a bag of water here, connected by channel to a bag of water here. And they're in vinyl casing. And what you'll find is that over time that they will slowly lose some of that water just coming out. You know how water is. It can get anywhere, and it can go anywhere. So it's going to come out of the bag. So I always order these by bulk because I use so many of them. I just put them in the freezer. Just freeze it. So then you can take them out as you need them, and they'll last you a lot longer. And this is what it looks like in. So what you've got is it goes under the upper lip, and the little bag goes in between the teeth. And it's what we call a pivotal splint. So it's not going all the way back, covering the full mouth. It's only covering between about cuspid and second bicuspid area. So what that's done is separate the teeth, give it a cushion that the person can bite down on, and at the same time, it's distracting the condyle slightly. So it will help the joint feel better, even though it's not going to treat it. It's helping the joint feel better, and at the same time won't let them clench. Now, the best thing is, and this is what sells every patient, because how many patients come in and say, I don't think I clench my teeth. You know, I don't clench. This will find out, because if they do, they'll burst the bags. And, you know, the record in my office was 4 hours. The guy couldn't get through the first night. But he was the guy who told me he didn't clench either. Of course, his collusion's like tabletop. So I said, well, let's just find out. Put it in there. And he could, you know, so he thought it was a defect in the bag, of course. It wasn't me. It wasn't me, right? So, but these things are great because it's kind of a game for them. Can you get back to see me in a week or two and not have burst the bag? And of course, when they bring it back, because a lot of times you'll see the heavy indentions in it, but they haven't really clenched hard enough to burst it yet. I say, well, you know, you're clenching some, but it's not being too bad. 80% of the patients can wear these things. You know, they're cheap and dirty, is the best way to think about it, because it's vinyl. Some people say, well, it rubs a little bit. You know what? It's not a $2,000 splint, you know, or whatever you charge for a splint. I mean, this is, you know, I think these things cost you about $8, so you can charge whatever you want to for it. But you can find out pretty quickly, and if a patient comes back and feels better, they love wearing them. Some people love wearing things. Then you're going to say, with pretty good certainty, I can get you better from the muscle problems with a splint. So it's better than jumping in, a lot of people want to put an anterior deprogrammer in or something like that. As I'll tell you later, don't do that. Use these because you're safe. You're not injuring the joint where with the anterior deprogramming you could be. And this way you're doing the diagnosis you need. So let's talk about nerve block injections. Patients come back to me for the thing and they're still having pain. They're no better, whatever. So I offer them nerve block injections, and you've got 3. And these will isolate the pain for you. So the one on the left there is an auricular temporal nerve block. This is the one that's the more iffy for you, but it's in the joint itself. And it's a fairly straightforward joint. It's right in front of the trachea of the ear. But you basically just palpate the head of the condyle as they close, and you can feel the condyle head under your fingers. It rotates. So when it goes back down, I've got it marked where it is. I make the injection and go down straight in until it hit the neck of the condyle. Boom. And then I turn my needle sideways and slide it behind it. And I use the 30 gauge short and sink it to the hub. I remember when I was in dental school, they used to, I know Dr. McDonald, my endo professor for memory, is back here, and he's, don't do that, you'll break the needle. Has anybody ever broken a needle off? And, you know, that's back in the days when you had to sterilize them. You know, they broke needles, but you don't do that nowadays. So I use the 30 gauge short because it tells me exactly how far I have to go in. It's no guessing. Plus there's less hand out here to shake while you're doing it. So, and then I go in and you're aspirating all the time because I use Marcaine with epinephrine. And Marcaine, if you inject it into a vein, can cause some serious heart problems. So you have to be kind of careful. But it's it's 9 hours long acting. So these patients come in, it can be a diagnostic nerve block, but why don't you help them out for a few hours and give them some pain relief? So that's the AT. That's not the first block I give. Neither is the one on the right, which is a lesser occipital block. That's usually coming from the neck, pain from the neck. And you'll see these pain, this is the pain that's right on top of their head. It's radiating up there, and that'll take that pain away from them. But the one that tends to be the best one is the one on the right here, which is the greater auricular. And the greater auricular nerve block, I know that looks a little awful to you about that bleb on there, but what you want to do is superficially inject this just under the dermis, because the auricular temporal nerve passes over the SCM right at the junction at the angle of the mandible. And right around that area is a sympathetic nerve plexus in that area. So when you block that, you're blocking the sympathetic nerve plexus in that neck as well. Oh, I'm sorry. Thank you. I was looking on here, and I kept thinking, okay, yeah, no, that's it. So that's the bleb. You're going to get a bleb up on the tissue. And what happens is it's very superficial. I inject this real slowly, and I want it to come up about the size of a quarter or bigger on the outside, and then just massage it into the neck. And these people that have had this, you know, when you ask them to put their finger on one spot that hurts and they go like this, this will help, because it's going to affect all of that area in the head around the ear and around. Now, if it's the true joint, AT injection, the auricular temporal nerve block is going to do that one. So those are the two that I use more. I usually don't do a lot of lesser occipital blocks much. One or two patients, but not many. But this one is the one I like best. Volume? No, it's just one carpule. I use one carpule of Marcaine. Yeah, slowly inject it in there, and just aspirate as you go. And you can see some pretty profound blocking. We use this diagnostically too, and we use it therapeutically. So what we'll have is patients that sometimes just are having trouble getting over things. If they're in there's a problem called CRIPS, Complex Regional Pain Syndrome. Normally it first was diagnosed usually in veterans or whatever from the Civil War was at first diagnosed, but it was extremities, where they'd have a hand blown off or whatever, and they were having pain that they just couldn't get rid of, but everything had healed. And CRIPS is a sympathetic nerve problem. Well, if you keep somebody in chronic pain long enough, and this is what we see in TMD patients, they get into a chronic pain patterning. And once they get there, sometimes it's hard to unwind them. So the sooner you can unwind that, the better. But CRIPS is one of the problems they get into. Now, this lecture's not going to go into CRIPS, but that's a whole nother manifestation of TMD issues. But one of the things I use with these patients is nerve blocking. And a lot of times I can interrupt that pain patterning, even if it's for just 9 or 10 hours. Well, what we find with this is that I'm doing it first one, like a block every 3 weeks for a couple of cycles. Then it goes out to 4 weeks. Then it's going out to 6 weeks. Then it's going out to 2 months that they're staying pain-free. So what you're doing is resetting that nerve cycle in the cervical plexus. It's so complicated in the head and neck with stellate ganglion and all that going around there that anytime you can shut it off before it gets deeper, the better off you are. So how do we treat TMD? Well, if my patient improves, and the way I look at that from initial therapy is their range of motion better, pains decrease. A lot of times I'll initiate conservative therapy. And I'll initiate the conservative therapy because a lot of times the MRIs are going to require it anyway, so you're going to do one. So if they haven't had a splint, I'll recommend a splint. Let's see where we go. And then what I'll do is follow that patient with splints and medication for 4 months. And that's part of my therapy. That's part of the fee they pay me is that 4 months hands-on, no more fees. I don't want them thinking I'm going to get charged again for getting a splint adjustment. I want you to come in and let me keep this adjusted. Because if there's another thing I can really pass on to you here, splints aren't they're not smart plastic. They don't, and people aren't acrylic deficient. I mean, what we have to do is put in a splint and keep it adjusted, keep it balanced, because it takes work. You can't just put it in and walk away and never do anything to it. But I can't tell you the number of people that come in and put the splint on the table because it didn't work is because the dentist never adjusted it again. And if he had just taken time to work with the splint, he'd probably been fine. But he just didn't work with it. So we do it with therapeutic nerve blocks too, as I mentioned, and then I'll reevaluate the joint after 4 months. So what I'm doing is looking after 4 months, okay, do we need to go deeper and look deeper about the joint? The CT is going to be giving me some indications, so I can kind of tell them, and I've got a patient I'm going to show you that happened with, and then you can get the MRI. A lot of it is diagnostics. The patient needs to know what's wrong with them. Even if he doesn't do anything about it, even if she doesn't want to have surgery, they have a right to know what's wrong with them. And if we've got the technology to be able to tell them what's wrong, let them make an educated decision about how to address their problems and not superimpose that on them, saying, well, you don't need an MRI. I think we need to if we need to have that information, we've got a bad joint, the joint's still a problem. If the splint doesn't stay adjusted, I keep having to adjust it, and the bite's in some kind of transition, then that's one reason. So I want to talk about medications a little bit. Now, I've given you a handout on medications that is much more thorough. So I've just put a couple in here that are the ones I use. So muscle relaxers, the one that we always go to is cyclobenzaprine. I use 10 milligram, I give them 10 milligram tablet, but I never have them take that. It's just because generically, that's going to cost $3. And if you gave them a 5 milligram tablet, it's going to cost $3. So what I do is give them the 10 until them break it in half, because it'll give them 40 days of it if they need it. But and I'll usually only write this one time. I don't give refills on, unless we're taking them through therapy and they need some, I'll give a second prescription. I very seldom give more than just one prescription of cyclobenzaprine. It can be addictive with patients. And also with cyclobenzaprine, most pharmacists would tell you it's really the only one that works. I mean, you've got Robaxin and Soma and all these others, but it's the only one that really works. Now, it's going to make you sleepy, but guess what? That's just a side effect, but it's going to help. And one of the side effects we really like about that drug is it makes you sleepy. Because the problem with these problems with people is they don't rest. If you don't get proper sleep and not letting your body heal, you're not going to get better. I had one lady travel from North Carolina, came down to see me. She was frantic about her head and neck pain problem. And it really got down to the point that she really didn't have a TMJ problem. She might have been clenching her teeth a little bit, but her big problem was she hadn't slept. She really hadn't slept. I did a cyclobenzaprine therapy on her. I put her on cyclobenzaprine for a month, and her problems went away because she started sleeping. And when she got into normal sleep patterning, she was fine. And I started coaching her on how to get that, what to take, like taking some Benadryl at night, whatever you need to do to help those patients long term to be able to sleep better. So we can use Valium. I don't like it. It's been around forever. It works. But once again, I usually would make somebody start off with 5 milligrams, not 10. But once again, it's a sedative type drug. Now, nighttime clenching. I had a guy was giving a lecture, table clinic at Restorative Academy once, and he was talking about bruxing. And the comment he made about it was that, when we get to these really severe bruxers, there's nothing we can do about it. And I said, well, have you tried trazodone with these patients? And he said, first comment out of his mouth is it in the literature? Well, it is now, but at the time it wasn't. And I said, I don't think so. And he just turned away from me. He wouldn't even talk to me. And I thought to myself, well, he stuck his head so far in the sand, he got it up his nose. But the problem is that these people get stuck on the idea that if it's not in the literature, they're not going to try things. You can try a lot of things empirically with your patients and see if they get better. I'm more about getting the patient better than whether it's in the literature. But that is in the literature now. Trazodone does help. And this is the weird thing about it. It's an SSRI, but it's not like most of them. Most of them are going to cause more clenching. Paxil, Zoloft, those are terrible about creating clenching problems in patients at night. But the trazodone doesn't seem to do that. Now, we give them 25 milligrams, so the smallest tablet's 50, because this drug's used for depression, in doses of 100 to 150 milligrams 3 times a day. But we give them 25 milligrams at night. And the only side effect of it really, and it helps them sleep, the only side effects is a dry mouth, which I have right now. But that's, it's only there while you're sleeping. So, and we use amitriptyline some. You can use amitriptyline as a clenching agent. One of the things about amitriptyline that's is effective is it can be used in migraine prevention. So you got a patient that's got migraine problems. Sometimes 10 milligrams of amitriptyline will help with that. So given it at night. And a lot of times you'll eventually wean the people off of it. Neuropathic pain, some of these pains that you're dealing with long term. I have a patient that's, for instance, got a really bad TMJ problem in pain and needs to have surgery, but can't have surgery right now. I'm going to put him on Klonopin, clonazepam, 0.5 milligrams, usually twice a day to 3 times a day, or to 4 times a day, but I usually don't go to 4. And I'll put him on the Klonopin. A lot of times I put him on there with Relafin, which is an anti-inflammatory drug that I'll talk about in a minute. But that's a good medication if used wisely. Gabapentin I use for one reason only, and that's if the patient, I suspect, it has trigeminal neuralgia. These people come in, trigeminal neuralgia is just usually very characteristic symptoms. They come in, it's a lacerating pain. It's usually induced by something like brushing teeth, cold air. The ones you hate is where they come in and some people like Dr. McDonald have got a hold of them and done 4 root canals on the top because they couldn't figure it out. I'm just teasing you, Tom. But I mean, there's endodontists that will do root canals on these patients, And the problem is that it's not a root canal problem. And so what the ibipentine will do is a neuropathic pain medicine, and you're titrating this dose up with the patient until the pain stops. So it's diagnosis. You know, a lot of times I'm given medication for investigation as much as therapy. So titrating that medicine up until I get to a stopping point. And if it goes away and they're better, and they come back and see me, then I'm handing them off to their physician to manage, because this is a management problem, drug management problem. There are surgeries for those, but it's not within the scope of this. And then NSAIDs are standbys. You know, I'm just going to say something. Something wrong about going to Costco and being able to buy 500, ibuprofen in a bottle like this. I mean, people take this drug, and it's a drug, like it's like it's some kind of candy. And it's any NSAID taken too much can create heart problems, any of them. So, and that's what really took the COX-2 off the market, is because of the heart issues. But any of these can cause heart problems. So it's dosage related. And so you have to be careful about NSAIDs. And I usually find that they don't work. Ibuprofen and Aleve don't really work as well on this particular type of pain patterning. And so what I use is Nibidone. This is Relafin. It's not the name in America anymore. It's the generic Nibidone. And this is in the handout. And I give them 500 milligrams twice a day with food. The good thing about this, as I'll show you, it's low acid. It's a very low acid content. And, but it's a great anti-inflammatory medication for this. The other one I use is Mobic, meloxicam. That works pretty well for this, for joints especially. It tends to help. And I never keep a patient on any of these medications for long term. If I have to have long-term medications, I'm switching it up. You get tolerant to medications, and they become ineffective in your body. So you need to be changing it up. I'd switch from Nibidone, go to meloxicam, go to ibuprofen for a while, then come back to the Nibidone. Same thing with any of the other medications I've listed up there. One thing I don't have listed there is well, let's mention the Celebrex, because the Celebrex is a good drug, and it's not used enough because people are scared to death of it. But it's used in a younger population. I wouldn't use it in somebody that's an old curmudgeon like me, but when you start getting into the younger population, 30 years old, healthy, no heart conditions, whatever, you can use this on short term, especially if they have any problems with acid reflux or problems, because it's more tolerant. It's not perfect. People sometimes still have some problems with this medication, but it's better than any of the others. There's another one you can use, Voltaren. Has a cream. It's a 1% that you can rub on. You know, I've tried that drug on my hands and stuff like that for arthritis, and I think you have to keep putting it on there about 10 times a day to make it work, but I don't use it enough. I don't like using those meds. So I want to show you this slide only for the outlined reasons, not to look at this thing. I don't want to even think about it. But you basically have two different types of NSAIDs. You have an acidic version all out here, and then you have the non-acid. And the non-acid is the Relafin down here, and the Celebrex is totally off of that, not even non-acid, it's not even an acid producer. But this non-acid one that's why I use that Relafin. Also, Mobic is this is going from left to right, acidic to more acidic, because that's carbolicness, indolic acid, so it's less. So I tend to use that. Once again, don't look at the slide except for the red box at the bottom. This CNS, these are acts of medication, actions of medication for muscle relaxants. And of course, over here is you have two different types. You have the CNS system that works on and what you're looking at from here. Let's see if I can show this. Yeah. So what you're looking at over here is central nervous. So this is working at the brainstem level, okay? And that's the drugs down here, cyclobenzaprine. So that's working and managing at the brainstem level. When you get over to CNS depressants, you're working on the limbic system, and that's Valium up here. Well, down at the very end, you have a drug here. It's called Xanax. I'll tell you a story about Xanax. My wife and I, as I told you, were high school sweethearts, and so we dated. I started dating her, I was 18, she was 16. And so we grew up together pretty much. I dated her all through college, and I got married. We got married after she graduated. She was a year behind me, graduated at Georgia, and I was a first-year dental student, finished my first year, and we got married. Well, sure enough, we lived in Atlanta after I was out of the Air Force. We lived in Atlanta at this one location. Her mother died. Her father had been dead for a few years. And so we bought the house from her brothers and sisters, her brothers. And so, and we moved in. We lived there 12 years from 2000 to 3 years ago. And so I told her, I said, you know, it's a great house, beautiful house in Buckhead, but it was on 3 acres of land. Our kids are all grown. There's nobody there. And Atlanta taxes are just horrific. So I kept thinking, we need to downsize. So I told her, I said, if you want to do it, anytime you want to do it, I'm glad, but it's got to be your call because this is your house. And it's just, boom, overnight, she found the house. She put a contract on it. I mean, it was like, boom, boom, it's done. And so we moved 3 years ago this May. But when she went to the closing, all of a sudden she had seller's remorse. It was like, I sold the farm. And she got depressed. And she has a little anxiety issues anyway. So they put her on Xanax for that. And she had, about a week after taking the medication, she had an incident in which she thought she was going to pass out. But she said she recovered and didn't think much about it. So sure enough, about that was 2 days later, we were up in North Carolina at our house. She was getting dressed in the morning, and I witnessed the incident. She looked like she was having a stroke. And so I sat her down, did kind of stroke protocol on her, and I could tell she doesn't appear to have a stroke. And I took her into the emergency room, and they did a CT scan, and there was no evidence of a stroke. So she has been through battery of stuff. She's been MRI, she had psychological testing, she saw her neurologist, Dan Barra, who's husband of Molly Winston, is head of neurosurgery at Emory. Dan got us in with an appointment. They had a neurology at Emory. They put her through a whole bunch of stuff. Bottom line is, her brain's normal, except she has lost 15 years of memory. And it's all the years we lived in that house. She has no recollection of being in her childhood home, has no memory of her grandchildren being born, nothing. It's gone. And it's not come back. Now, she's come to grips with that. I mean, it's been hard for her. But she's come to realize that's happened. But she remembers our children being born. She remembers us living in our first house. She remembers our dating. She remembers all that stuff. She's just the most recent. So every time she goes back to that, I just don't want her to dwell on it because it's not going to be helpful. But all of the neurologists basically all concurred it was a reaction to Xanax. Well, in the book, Reversing Memory Loss by Vernon and Jeffrey Mark, the authors state that memory loss can occur with one dosage of Xanax. Now, I don't know why this drug's still on the market, really, because anybody 60 or over should not be taking it. If you're taking this medication, you know a loved one taking this medication, they need to get off of it. Because I think it's, in our age of Alzheimer's and everything else, you don't need to add this risk to it. I use Hippocrates. This is a great little app you can put on your phone. If you don't have it and you need it, it's great. It's free. It pulls up all your drugs. You pull up your drug, you type it in, it'll tell you dosage, contraindications, blah, blah, blah. So if you don't have this app, it's a great app. Use it in the office all the time. So let's talk about treatment planning, the damaged TMJ. And we're going to talk first at the tooth level, okay? That's your job, in the mouth, at your office, okay? So the first thing would be indirectly, okay? Well, what we do is splints, and we do all kinds of different splints. I'm going to go over the different types of splints that are available to do, and I'm going to tell you what I think is best. But you have to remember with splints one thing. Splints don't treat joints. They're not going to make a joint better. They're not going to make, if the popping went away, that hasn't fixed the pop. It's not fixing anything. It's just making them more comfortable. It's treating muscles. But muscles feeling better can make people feel a whole lot better. So sometimes that's all you need to do. We'll look at medications, okay? That's next level we do. We always give that with it. Look at physical therapy and chiropractic, and we're going to talk a little bit about the options for that. And then injection therapy as well when we do that. Then we will look at directly doing this, and we look at reshaping like occlusal adjustment. A lot of people, like I say, will do occlusal adjustment, but I'd caution you to be reluctant about adjusting bites until you're really sure if you got a potential joint problem, why did the bite change? So all of a sudden, if it's a restoration you put in, that's one thing. But if all of a sudden they're complaining that they're hitting on this tooth, why is that? You need to start thinking a little bit outside of the confines of let me pick up a drill and get off the interference. What caused the interference? We want to look at reshaping the occlusal. We look at repositioning the ortho, repositioning the teeth, orthodontics. Want to speak, I really need to be getting in front of orthodontists more than anybody else because, they could really save themselves a lot of heartache by retreating that class 2 that failed. And, believe it or not, it wasn't because the kid didn't wear his retainers. It's a lot of times these relapses to class 2s are because of bite problems at the joint level. So one of the things orthodontists can do early if they diagnose that is actually putting a patient in a herpes appliance. If the disc is recapturable under that herpes, you can finish the growth of that condyle. And that will help that joint. Not going to recapture the disc, but you're not going to end up with a osteochondrosis of the condyle, which is important. You can talk about restoring. Obviously you can do something at the tooth level, like trying to bridge or some type of restoring. And we talk about treating it at the damage at the surgical level. This is treating at the soft tissue level. And let me just say this about surgery, okay? Most oral surgeons don't want to do it. There are very few that even want to open a TMJ, and there's a reason for that. 1990s, late 80s, 90s, there was a big wave of TMJ surgery in this country, and it was the ProPlast implant bonanza. And so Teflon implants were being put in, and this was a panacea. This was the end of all TMJ problems. We're taking out the disc, put this implant in. It created giant foreign body reaction in these joints, and I have got several patients in my practice that had to have total joint replacements. I have one lady who it eroded the skull base. So it was really bad. Well, you can imagine the litigation heyday lawyers had over that. So now the best way to not get in trouble like that is don't treat it. So most oral surgeons don't. They just. In fact, that's the reason I got hired at Oral Surgery Associates. They didn't want to mess with it because it bless their hearts, oral surgeons are good at putting it in and taking it out, but they don't want to do any talking much with them. So, they've got to get on to the next case, So if it's not an implant or not a wisdom tooth coming out, then talking to somebody about their problem or manage it with a splint, it's just too much time consumed for them. And I understand that. They got a business to run. But at the same time, these people are left holding the bag. They have no place to go. So where can you get surgery done? Well, biggest thing is mostly hospitals, institutions that have teaching centers like Emory has an oral surgery place, Kentucky, LSU, University of Florida, they'll do TMJ surgery there but TMJ surgeries are TMJ surgeries, and I'm going to show you kind of a level of TMJ surgeries we go through there. And as we go in through these surgeries, I want you to keep this in mind. Please do not tell your patients, whatever they do, don't have TMJ surgery. I hear this all the time. They come in, that's first thing out of their mouth. My doctor said, whatever I do, I shouldn't have TMJ surgery. Well, just tie my hand behind my back, because that may be what they need. If you were sending somebody to the periodontist, last thing you're going to say is, don't ever let them do a gum graft on you. You want the patient to get the best thing they can for them. And surgery is a relative term. There's mild surgeries that are not that invasive, but you know what? Give them an option. It needs to be on the menu for them to look at. So looking at the surgeries, and these are going from least invasive to the most invasive, okay? So the first one's arthrocentesis, okay? That's sticking a needle in the posterior part of the capsule, sticking a needle in the anterior part of the capsule, sedated patient, obviously, and flushing it out, usually with just saline, and flushing it out. So what are you gaining by that? You're flushing out cytokines, inflammatory processes, moving the joint because the patient's sedated, so you can kind of get freedom of motion. And then you take the needles out, and it's just going to scar back up usually, or something. But nothing's been changed. You just flushed it out and made it feel a little better. And one of the big things, patients are sedated, a lot of times their range of motion, the surgeon says, I didn't see any problem with his range of motion. It's because he's asleep. The jaw just plopped open. But What you find is arthroscopy is another version of that. Now, once again, they stick 2 needles in and put a 3rd needle with a scope to look at it so they can see what they're doing. And they can see that they're fleshing out the joint, and then they take it out, and that's about it. And the truth is, the evidence now shows that flushing it with hyaluronic acid or cortisone or anything is just as good just to just do it with the saline and leave it, because it's not going to change it much. And what you find with both of these cases is that they're not effective. 75% of the people notice some lessened problems right at first, and then boom, it just kind of went away. 25% had any long-term benefit of either one of these. So you can do a disc repair. Now I told you if it's a Piper 3, you're not going to do surgery with this patient. It's a Piper 4A or 4B where they've lost the disc and you want to get it back on the medial pole. So surgery can. Now the key to the success of this is fixation, because this is a translating joint. If you did surgery on your knee, you're going to immobilize it for a while. This has got to be immobilized for a while. And when you go to and what you're sewing is the retrodiscal tissue to the disc itself. It's like sewing tissue paper. I don't know if any of you ever have witnessed a number of TMJ surgeries, so it's difficult surgery. And but it's really fine tissue and really soft, so it's fragile. What I mean by proper fixation is you've got to put them in a protruded position slightly to let it be under the disc where it's going to heal, and they stay there. Now, you take them out and let them exercise every day under controlled circumstances, but they're not chewing or eating 4 months to let it heal. Everybody goes, oh. But it is what it is. I mean, it's just the only way it can let it heal. The body will do it. You got to give it a chance. Okay? The problem is there's a lot of people don't fixate it. That's why I say with and without. Because you end up these people, they don't fixate it, and then it just tears, and they say, that don't work. Well, of course it didn't work. You didn't fix it right. So then the other is a discectomy with or without a fat pad insertion. Standard of care is still in the books. Take out the disc and close it up. What in the world? What brain trust thought that was going to work? There's nothing in there to protect the condyle against the bone, except for a blood clot that eventually will wear through, and you're going to have problems again. And that, it gives the surgeons another opportunity to do a surgery. So here's the problem is, if you're going to take the disc out, you need to put something back. Now, there have been all kinds of things. I didn't list temporalis flap or lateropterygoid flap. There are all kinds of ways where people will cut a piece of the tissue and flap it under there and screw it into the back of the eminence and all. They don't work. They just don't work. What works is fat. Fat taken is suprapubic fat. It's dense and it's injected into the bone. Ladies, they will not do liposuction on you when you have this done. So it's just a little teeny bit of fat. But it's taken out and it's put in the joint capsule. Once you take that disc out, the best surgery is to actually take the retrodiscal tissue and sew it to the lateral pterygoid muscle. When you do that and then inject the fat around that, it will heal. And this is where we're finding that the lateral pterygoid is not as prone to nerve problems or pain or compression as we thought, because we're doing this now, and they're doing this now in the surgeries. So this is fat surrounding. To get that to heal, you've got to stabilize and mobilize the joint. So they are in bite splints that are open in the posterior more than they're open in the anterior to distract the condyles and give that fat a chance to heal. Fat is squishy and soft. But if you allow it time to heal and maturate, it will get fibrous connective tissue between it, and you will get the substance of a pad. It actually has been shown by Mark Piper to establish a blood supply, which is because it's so seeking that anyway, which is helpful. So as that's doing that, now here's the good part. It's 9 months of fixation. And that's the problem, is that people don't want to put up with that. And when they fixate them in that, they're going through exercises every day, and every day you're coming out of the splint more and more, and it gets to the point where about halfway through you're just sleeping in it at night. But the problem is you've got to let the fat heal. And if it doesn't heal, it won't work. It's amazing. God will take that tissue and make something out of it. But it works so much better than artificial. And the cortical covering of the condyle will remodel. You actually see it on the CT scans where it actually regains some of its shape. Not completely, but it does show that it's trying to take it. So those are the best. There's only 2 people in the country doing this correctly. Mark Piper in St. Petersburg, Florida, and Ed Zibovitz in Bowie, Maryland. And those 2 guys are doing this surgery and having success. But it's all about the fixation process. We need more surgeons doing this surgery. And you know, the truth is, they're out of network. I mean, insurance would pay them $2,000 to do this. So these surgeries are out of network. It's all out of pocket for these patients. But it's all about, sometimes when my daughter had hers done, I had to fight. I had to threaten to sue the insurance company to cover. And at the end of the day, they paid me half of the surgery back, which is out of network, fine, what I would expect. But they ought to be able to get that, but they'll fight it. Insurance companies don't want to pay this. But these guys can't take that insurance coverage because they won't get paid. But we need more of these guys doing this kind of surgery because these patients need it. So we're going to talk about treating at the hard tissue level. When you've gotten to where you can't really save the condyle, your options are condylar reinforcement. What they do is take a rib out of it and do a grafting. So that's your new condyle. And the joint, he actually leaves some of the cartilage on the rib to form the cartilage of the joint. It's a bad second, but it's the next stage. And then condyle replacement, artificial joint. You know, if you get to that point, and there are points you can't save the joint, you know, most institutions like up in Lexington or Emory or any of these are going to be able to do that fine. Emory does a ton out there. Gary Ballou probably does hundreds in a year. So, I mean, they got that down. So you get to that point, you do it. But, you know, it's like there's a point that you need that. I mean, you know, I've got an artificial left knee. I'm one of these little guys that thought I could play football in high school, you know, just got killed. And so I've been living with a bad knee all my life. I could be limping around like some of you are right now because you don't want to get the joint fixed. But 10 years ago, I had this joint replaced, and life has been so much better. I'm active, I can do what I want, and I'm pain-free. So there's a choice to make. Sometimes you've got to go that route to get pain-free or get comfortable, and patients have to make the choice. You need to give them the chance to make the choice. So, and then this is the last one. There's a group out in California who actually does this. They don't even look at, they got joint problems, but they've got a bad bite discrepancy, so they do maxillary mandibular osteotomies, which is a hugely more invasive surgery, and then they put them on immunosuppressive drugs to keep the joint from flaring up on them. So, not a good way to go. So let's just talk briefly about the psychological level. This was the class, the Axis 2 I was mentioning about. And counseling, you know, a lot of times just some counseling for people would be helpful. Medications that they can get on, anxiety medications that don't affect clenching, and there's some out there that, but what they need to be doing is talking to y'all and find out what can we use, what can't we use. So you need to be the, you know, kind of the clearinghouse for that with a psychiatrist, not the other way around. You know, if they're trying to look for it, because they're usually fishing for a drug that's going to work on the patient. Why don't you give him some options first? Don't use Paxil, okay? All right, so exercise, biofeedback, exercise. I mean, these are things that help people, you know, so that's always being advised. Healthy living is an important thing. You know, I've gotten to a point now in my practice that if somebody comes in and is a smoker and won't quit, I won't treat them because they're not going to get better. Smoking is one of the worst things ever. And if they smoke, I'm not going to make them a splint. I'm just going to have to seek care someplace else because they just won't get well. So let's talk about other modalities of treatment because we mentioned this early. Physical therapy, everybody, you know, physical therapy works. But what does it do? It's modulating the pain, right? So you're looking at pain modulation. So, and that helps. It takes it away. You know, teaching people proper posture, helping those, you know, actually doing something with posture, I think is more important physical therapy-wise than just putting them on a bed and sticking needles in them. Because dry needling seems to be the big thing with physical therapy, and that works. But you know what? 2 hours later, they're still back in pain problem. So my feeling would be is if you can teach them lifestyle problems, proper and exercises to help with posture like they do if you've got a knee problem, whatever, that would be more. Then we're talking about Atlas orthogonal or NUCA. That's Northern Upper Cervical Spine Association. So these are people that deal with Atlas. The Atlas orthogonal people actually use a machine. People that developed that started here at Atlanta, the Sweat father and son at Sweat Institute. And they use a machine to set the Atlas. NUCA is hand manipulation. And it all feels a little bit, Ginzu, like I said, to me. But the truth is, I've had success with these patients. And I've been through both of them. And, but I don't have an Atlas problem, so it's hard for me to give you a valid thing of whether it works. But I've had people have some success. I've had others that won't hold. It doesn't give them success. This is the one that everybody wants to know about. Can I give them Botox? Well, let me just tell you what, there's not one piece of literature that shows that Botox works. No controlled studies have ever been done to show the efficacy of Botox and TMD. So you want to use it, that's fine, but all you're doing is paralyzing the muscle. I don't know, when I was in school, we had this really wild man for microbiology. A guy named Claude Terry. He was a wild guy. And I knew him because he was in the boating circles too. But it ended up coming to me as a patient later, which is a whole other story because it's funny. But Claude, I was pipetting up botulism toxin, and I remember him looking at me and says, "Don't suck that down your throat. A teaspoon of that will kill 1,000 people." It's stuck in my mind ever since, and so my wife is not going to have Botox in her head. Now, you can tell me that the molecule's different and all that. It is a neurotoxin. So you do it with what you want, but I don't think it's going to help you. In fact, I saw a report where a woman got atrophy of the anterior temporalis by overdoing it for temporalis headaches, and she ended up getting the Herman Munster look, bones sticking out, okay for a man, not really cute for a woman. So diet and exercise, as I talked about, that's really important. Proper sleep patterns. Get the people on a neck pillow. You need to be treating some of these neck issues. This is not really the time for that. But we want to, because we want to get on to splint therapy and finish you up. So, why do splints work? I tell my patient it's magic. I don't know. You've got all these reasons why. It's basically giving the patient a perfect bite. That's what you're doing. You're giving them a perfect bite. And you have a calcaneus bone in your heel that has all the muscles on the floor of your foot strapped to it. That muscle is sort of the focal point for your balance when you stand up. So when you're standing up, rocking back and forth, that's your place in space. It starts at the calcaneus. Think of your teeth as 28 calcanei, because you've got that in here and you're finding it in space. And that's why splints with good therapy, not by itself, with therapy, physical therapy, other things, helps. Always build a splint for a patient that's doing Atlas orthogonal, because I know it's not going to work unless I do. But there's a lot of good, bad, and ugly with splints. I get all kinds. Let me also make a blanket suggestion. Vinyl splints don't work. Just if you're making them, don't make them. Because all they do is they're chewing gum splints. They basically teach people to grind more, because they'll just chew on them, especially if they're heavy bruxer. So it's got to be a hard splint to do it. So properly made splints treat muscles, not joints. They can make the joint more comfortable, but they're not going to solve the underlying structural problem. And improperly made splints, and I'll show you as well, will make it worse. So you've got to be careful about what you're making. Now, we use BioAcryl ice in our splints. They're clear now. I used to make them out of cold pack, but we pressure cook them to make them dense. And so this is one of my old ones, so you can see the markings. I use Tanner type splints every time I can. I like them because they're easy on patients. You build it right, a lot of times they can talk with it, they can wear it, but an upper splint will do the job. They both do the same thing. The reason I like a Tanner style splint is it's the movable jaw. It's on the movable jaw. So when you're trying to find those calcanei in space, you're going to locate that where you want to. So I like to have it on the movable part instead of on the fixed part, but it'll work on the top. I've had success with those too. So this is what we want them to look like when we do them. I want to see broad contacts, not just the pinpoint. We used to think pinpoint contacts. It needs to be 1.5 millimeters to 2 millimeters wide. And the reason we want that is because I want a long centric. Of course, I don't know, we ought to use a different word besides centric, because but that's what the term is, long centric. I don't want them feeling locked in, because if they got a disc that's out of place a little bit, I want them to come forward if they feel comfortable there, because they may. So I give them freedom in that. No contacts, as you can tell in the anterior here. In the black, just red. And these contacts are black and then slightly red on the outside, then disclusion. And I want pretty uniform disclusion across the front, and as you saw, very low. I mean, I keep flattening that anterior guidance as flat as I can get it and still get disclusion. That's ideal for me. Now, you can make a total flat splint and put them in a group function, and those will work too, if you want to do that. So those will work. You know, the dental community was throwing a line several years ago that this was the solution to all clenching problems, clenching and grinding problems. And we swallowed it hook, line, and sinker. And I'm telling you, I think we've all realized that this is not the answer to everything. You get flaring of the anteriors, you had a extrusion of the posterior teeth, so then they solved that problem. Everybody put full coverage on it and just put a contact in the front, and then they made them on both sides, and everybody had to put their name on it. It had to be a Eubank splint or E splint or B splint or Coy splint, but basically everybody was naming these splints. But at the end of the day, they're an anterior deprogramming splint. And the problem with it is that if you don't know what the joint is, the condition of the joint is, you can make it worse. Now, if this person has no joint problems and they've got a terrible grinding problem, it will stop the muscle. But if they are a Piper, like a Piper 3B, and you put them on this splint, and just think of the physics. You're biting on the front, but you're not going to stop clenching, okay? So you're biting here, not stop clenching. These master muscles are contracting. And when they do, they're going to force that joint up and back. And what it's going to do, it's going to force it off the disc. So you're going to make a 3B a 4A. And I've seen this happen too many times. So I don't do these anymore. I used to have some of these little Lucia jigs and make I don't even do them anymore. If they can't wear the aqualizer, then sorry. Tap appliances. These are anterior repositioning appliance, okay? But they're also an anterior deprogrammer. And one of the things you have to look for now, and TAP, at least TAP does this now, is give you posterior stops. You can ask for these. So when you do your TAP appliance, make sure you have a good mounting to show it and ask for posterior stops on your posteriors. That way, if they have a joint issue, they're not going to overclose this and make it worse, which they may do. You can use TAP appliances in people, especially up Piper 3s, not a problem. You can use it on a 4A. If they recapture the disc, it's absolutely better if they come forward and do that. It's where you get past that in the 4Bs and 5As that it might be more problematic for you. But they're great appliances. This is called a Simmons splint. Cliff Simmons in Nashville makes these. I'm sorry about the photograph, but I just stole it out of the article he had because I don't know any other place to get it. But what you've done is basically take two shims on the top, and this is acrylic that's been fixed together in an anterior repositioning format, and he leaves them this forever. They live in this. I don't even know if they take it out to eat, and then they put it right back in. I mean, to me, quality of life just goes down the hill when you add these things. And the concept is we're recapturing the splint and, the disc and whatever. You don't. Or you just teach the people to live out of a bite that they can't really live in anymore. So I don't like them. Worn dentition, really worn dentition. You can't get the person to stop. I make them an increased vertical split. Well, sometimes they'll open these people 10 to 18 millimeters in the anterior. Got to put them a blowhole in there, though, when you do it. But when you do that, a lot of times that will stop them from clenching. They'll just, for some reason, just quit, and it works. So let's run through a few cases. Got about 15 minutes. So let's run through a few cases, okay? So one thing I want you to remember with these patients is just adult open bites or adult bites that are changed dramatically in your practice. You've seen the patient for a year, all of a sudden they've got a bite problem. Don't just pick up a handpiece and start adjusting. Start thinking about where it's coming from, because as you can see, this is an MIP on this lady, and this is her fully seated. So something's wrong, okay? So this is Emma, 17 years old. She was told she was genetically class 2. Had ortho and then mandibular osteotomy to advance her jaw a year later. She started to relapse. She's in pain. Can't find her bite. She's also in enclosed lock. She's range of motion is 28 to 32. That's her MIP bite. There's a fully seated bite. Okay, this is where the orthodontist all too often says she just needs braces again. That's not the right decision. That's a poor judgment call. So you need to start thinking, okay, why did this fail? She's been repositioned and screwed into place. What's going on here, you know? So that's another look at that. Well, here's her, now I'm going to do these on the first few slides. I'm going to do this so that you see the outline. Then the last ones, I'm not going to do it. Hopefully you can kind of pick up and start looking and see it for yourself. But you can see what's going on here. And this way this reads, this is the left joint. These are always medial pole, because remember, that's the defining pole of whether it's stable. So I'm not even looking at the lateral on most of them. So it's the left condyle, medial pole in the fully seated position. And you can tell she's off the disc. She's got a changed condylar neck, sclerosis. See how dark that color is? It's bone that's hardening in there. And she's got some beaking of that disc. Right medial, it's off, but look at this. Medial pole is osteochondrosis developed. In some way, she's got a smaller, so she's got this pinpoint coming up there on that one. So when she opens, and TCP is translated condylar position, so that's just fully open. You can see she pushes the disc ahead in both places. So the problem is she's a Piper 4B, almost 5A bilaterally. But here she's being treated orthodontically and surgically. You know, this didn't happen yesterday. This happened as a little kid because she has damage in the right TMJ that shows growth problems. So this is a long-standing problem that could have been, it could have saved a lot of heartache for the family and the practitioners if they had done the MRI first and say, we've got a joint issue, now how do we address it? Does it change your protocol? Maybe not. They know it. This father was a high-powered lawyer, okay? And he comes in and starts grilling me when I did the consultation because I was reading the MRI with it. And he wanted to know, did the braces do this? Did the surgery do this? And of course, I could honestly say no, because it was there before that, okay? And he never asked me that question. And I hope I don't get deposed. Okay, this is Merritt. She's 33, 22-year history of bilateral jaw pain. Pain varies from a 2 to 10 on a pain scale of 10. Worse in the mornings and evenings, under function. Started locking in middle school. Ortho, age 12 to 15, bilateral extractions. We see so many people who have had bilateral extractions. Extraction, retraction, it's crimping the growth. She had splints placed starting at age 22. She had an atlas that was about a 2+, so she, out of 3, so she was hot in her atlas, so she had some neck issues, multiple splints, and anterior programmer made it worse. It wasn't surprising when you start looking at Merritt. So if you look at her MIP here, it looks pretty normal. You see this all the time. Little worn size ledges on the cuspid, but when you get the fully seated, you can see bloop, it's lopsided. So this is her scouting image. This is the first one we do on that patient. So it's an axial view looking straight up and down through the skull. And you can see here over on this side over here, that's the TMJ in that area and a TMJ here. And because this is T1, remember it's fat, I'm seeing a black one over here. I'm thinking that's not good. So as we go in this, the next one is the T1 left, and this is the left side. This is T1. And so we're looking at the health of the bone on the inside. So fortunately, on her left side, she's got a sclerotic developing TMJ. So it's getting hard and beaked, but she doesn't have a disc there, but it's not damaged. If you look at the right side, however, over here, the problem is that she's got this is the T2 image, so this is swelling. She's got swelling of the condylar head. So there's damage going on at that level. And you can see how overclosed she is. That's why the bite had shifted so badly. There's nothing up there. So when she opens, she's bone to bone. She's 5A bilaterally. She's been this way for 20 years because it was there before that. So, this is stuff that we can intercept early and help these patients out. So for her treatment, is trying to figure out what she wanted to do. I told her long-term, you could do it. Surgery is what she needs. But you could do a splint, manage her on Klonopin and Relafin and this sort of thing for a long period of time. But she chose to do it. She had discectomy with fat pad and did remarkably well. The beauty of the fat pad surgeries is they go pain-free. Patients go pain-free after the surgery, which is what everybody wants. This Tracy, 32, Tracy was referred to me by a periodontist here in Atlanta. He saw the sudden bite change. Great. So he sends her. She had no real pain, but constant ringing in her ears. So that's the reason she hadn't really brought it up. It's just the ringing. And we see this. One of the hardest things to treating patients is ringing. She had worn soft mouth guards. She had a motor vehicle accident in 2001, so that's just another trauma. And they're all accumulative, as I told you. And her range of motion wasn't too bad. She's still under 30 and 40. Excursions were normal, but she had a 3-4 millimeter overbite. And she started noticing grinding noises. Now, the first thing I would look at Tracy's profile and think, this has got to be childhood, because look, she's got recessed chin, she's got no growth there. You know, I look at her bite, this is in the fully seated, the bite's messed up, I think, this is growth. This is going to be osteochondrosis in the joint, but it's not. Normal joint development up there on both sides, and they're healthy joints from the standpoint of these are T1 images on the left. So they look healthy, but the disc, I haven't outlined it here, but you can see it. Here's the disc here. Can everybody see that? And over here on this side, see the lump right out in front? There's the disc right in front. So they're fully seated, they're not there. And when she opens, as you'll see here, the right side, it pushes the disc out. So she has no contact. She's bone-to-bone contact now. It fully opened. And over here on this, that there's something interposed there, but that because this is proton density and it's not showing it as black, I kind of wonder whether that's really disc material or just something in there. But she's got some space. So she's a Piper 4A on the left and a 4B on the right. She had discectomy fat pad graft, and she's doing great. She's actually under care right now, orthodontic and restorative. This young lady, we ended up treating, she ended up with morning headaches. She's had all the different types of splints, Cloyce, E-splint, ADPs, all these things. She'd been placed on Zoloft, okay, so she's grinding more. But her psychiatrist didn't want to take her off that because it worked. Her atlas was really hot. She had a bad overbite. So I'm thinking, bad joint, but her joints aren't bad. She's a long-standing class 2, been that way forever. But the interesting thing about her case is her condyle her disc doesn't move in protrusive movement. It's isolated position. You can see on the left, the disc is up here, and this is like she's on the posterior band, but when she moves forward, it stayed there. It didn't move at all. So, but when she goes to full opening on these discs, it recaptures. But the other thing that's very noted, she's hyperextending. She's hyper-opening. A lot of these patients have loose ligaments. They're hyperactive in the joint, so you have to really guard them. Don't open too wide. So this is the thing that I found interesting about her is that this is the coronal view. This is in fully seated. The disc is off to the lateral pole and fully seated. You can see it out here. But what's the bad, troublesome part, this is taken on the other side. This is translated conjugate, fully opening. It goes medial. So it's sitting on the lateral pole, but when she opens, it's slipping toward the medial. She's at risk, but we just made her a splint and told her if she has any changes in the bite, we need to see her. But she's doing fine with that. Anna's 23 years old, suffers from a disease called POTS, postural orthostatic tachycardia. So she's fragile. Hit her head as a teen, suffered headaches, joint noises, pain on chewing, jaw locks all the time, cervical neck pain. She's been under the care of 2 neurologists, 3 chiropractors, gone through PT, psychological counseling, currently under the care of a cardiologist, and she was referred to a TMJ specialist in Atlanta, and he came to me for a second opinion. This is what he put in her mouth. It's basically a non-fixed Simmons type splint that just keeps cranking her open in the back. And she could take it out, but he wanted her to wear it 24/7. And so she was just never getting better. And he said, she asked him, well, when are you going to do something? He said, well, when you get better. So she left, came over, and this is what she ends up. This is what you see in these cases. And so she got a TMJ problem, but he screwed up the bite, because now she doesn't have any posterior occlusion. So poor girl was leaving, off on a trip, and go to Canada, not Canada, but California. And so I just told her quit wearing it. And this is her joints here. So you can see she has osteochondrosis. So this is a long-term problem for her. She's off the disc on the right one, but not on the left. And when she translates fully open, and you can see that where the rare error is, she's starting to tear the disc tissue, which is very rare. Tear the retrodiscal tissue, but not that. So she's looking at other surgery. Russ is 72 years old, no previous history, recent onset, myofascial pain, complained right here. It just hurts, doc. And wanted something done. Well, you look at his bite, it's steep, had a lot of, non-dentistry over the years, just did whatever was necessary. So this is the panoramic x-ray that was sent to me, okay? Looks normal. Most people look at that and say, well, the condylar neck's a little different on the right, but most people would read that and say that's a normal TMJ, or that's the way they send to me. Well, he's the guy I showed you that had a little bit of an issue up here in the upper right corner, that something was going on, and this is the joint on the CT. So I said, your joint's bad. He said, but I'm not going to do surgery. I said, okay, we'll make you a splint. And he did great, loved it, no pain, whatever. Then he comes back, never had any pain in the joint area anyway. Comes back to me, he says, I can't get my teeth together on the right side, on the left side now. He said, splint do this to me? I said, no. What the splint has done is diagnosed it, because now that you've relaxed the muscles, that joint on the right is a lot worse because you're over-closing prematurely there, and there's a pad on the left that keeps you open. I said, you can get this back to normal. You just take the splint out and go back to pain, and you'll get the bite back. Oh, no, it's fine. So this is what his joint looks like. You can see that right TMJ is gone. So this is avascular necrosis of the joint that has been going on for a long time. You can see the eminence is totally flattened out from where he's worn it out. But he's happy. He doesn't want to do surgery. Said, just wear your splint. You're just not going to have as much occlusion over there. I would not restore it over there either at this point. Let him live without it. So you can see him when he translates forward, he doesn't connect with it. So let me go in the last couple of minutes here. This is Lucy. This is my daughter. So we talked about her, but we never talked about her care. So this is where she came in April 2002 to Mark Piper's clinic, and as you can tell, she can't get her front teeth together. So she's gone from bad to worse being in Vienna. I made her come home and do the workup with Piper. She did. He said she needs surgery. And so I said, well, you're coming home. So I talked to Pete Dawson, and he says, don't wait, because his daughter Ann had this surgery too. He said, don't wait, because it doesn't get better. So I made her come home. She just kicked and screamed. She wanted to stay one more year, and I'm not going to have any friends. And, as it turned out, she came, started working at Whitfield Academy here in Atlanta, met her husband. They have 4 kids now, so she owes me some gratitude for making her come home to have it done. She was a Piper 4BA and a 4B right, okay? This is Lucy at age 42, okay? I want you to see the devastating scar that surgery left, okay? So this is what the incision does. It comes right here at the front of the ear. That's the line right there, and it's right down the trachea of the ear to there. So there's nothing to show, even for a guy, okay? And this is not, it's the protracted healing is what everybody hates. But if you're going to fix it, you got to fix it. This is her bite, MIP. This is where she lives. This is her fully seated condylar position. So she's got dual bites. You see these in these patients, but she's pain-free. So therapy, she lives in a splint at nighttime. That's all I do. Not going to change that. And if she ever needs restorative, then I'm just we're going to deal with that when we cross the bridge. But here's my take on restorative. Restorative in these cases needs to be, you got to be careful about putting in too hard a material. And I'm going to get on a bandwagon. I'm going to get on the platform here. Anybody cut off a zirconium crown this year? Okay. There's an old saying about, there's a thing called sacrificial devices they make in engineering. And it's the device that will fail in order to protect the whole structure from failing. And when you put in zirconium, you've taken on a second molar and put zirconium in against zirconium, you've taken away the sacrificial device of microscopic enamel wearing, because we all do it. It's not a static system, it's dynamic and it's changing. So you've got to gradually let it adapt, and there's one material that will do that. And I love Jack Turbeville's comment about it. You have 2 options in restoring second molars. Go old or find another dentist. And the art of doing gold restorations has been lost in this country. We're all being sold a bill of goods about everything's got to be white. I've got a mouthful of restorative of gold that was put in 1973. And the only thing that was replaced with that is Leon put a gold crown on number 18 20 years ago. All of them were, but except for Leon's, were cemented with zinc phosphate cement. I mean, some of the old stuff works better. And when it comes to stabilizing these posterior bites, gold, long-term is what you need to be in. In the meantime, composite onlays, these things, PMFs, you can do them, have them milled, and glue them right to the top of the teeth. That's the way we restore the posterior occlusion of these bites. And a lot of time what we want to do with these things is establish the second molar occlusion in the patient, get that stabilized, and then let the orthodontist close the teeth together. And it works. But it's most important in these graft cases to make sure you've got stable posterior occlusion. So just a quick word about prevention. This is a lot to the hygienist. Watch it keeping them open. Watch using bite blocks. You know, you can use a tap device. That's not a problem. And I'd also recommend you, if you're interested in this, Mark and Jim McKee teach a class on this called Fundamentals of Foundational Occlusion. Great class, and it'll give you a better understanding of what's going on. And I'm telling you something, I make the living, but these knuckleheads make the living worthwhile. So it's been a pleasure being here, and if I can answer any questions, I'll take them. So.